Is DK there? DK?
Good morning, sir.
Good morning, DK. All set. Yeah, that's good.
Morning, sir.
Both should be visible. Yeah, very good.
Sir.
Good morning, everyone. I welcome you all to the first Voice of Young MSS webinar. It's all about ankle. Now I would like to hand over the charge to Dr. DK sir, who is the Secretary for Musculoskeletal Society. Sir, please take over. Sir.
Yeah. Good morning, all. I'm happy to announce this new platform for the webinar, the Voice of Young MSS, and novel initiative by Muscular Society of India. And we are very fortunate that in the first session we have the stalwarts like Dr. Professor Mahesh Prakash, and we have the Guru of MSS Cardiology, Jayaraj Govinda sir, who is our honorable president too. So, without wasting the time, okay, let's give the chance to the young members who are ready to perform well, and I transfer this to our honorable president, Dr. Jayaraj Govinda sir. Sir.
Good morning, everyone. It's a wonderful Sunday, a very pleasant morning, and it is my responsibility and happy cheer to welcome this wonderful initiative of the MSS India, the Musculoskeletal Society of India, which was started almost 11-12 years ago at Vijayawada, and we are able to now get together a band of very enthusiastic, energetic members who are very, very interactive. And we have chosen for this particular program, which is going to be going on and on for some time, to encourage the young and very dynamic and very talented members who have joined the MSS with the passion, and we would want them to be active. And in this activity, we are going to generate a lot of sharing of knowledge, deep discussions, which will take us very far in our day-to-day practice. There will be so many permutations and combinations that we will not be able to understand. But when we share it among our groups, believe me, it's something wonderful. The discussions that we have on a day-to-day basis based on the case of the day from the MSS India, generated again by our very, very dynamic Dr. Dharminder K. Singh, and of course the seniors also helping along, my peers and my colleagues, all doing a wonderful job. I'm totally enthralled and very happy that this is going to be set off in a very nice morning. I wish all of you, including the faculty, the young faculty, the best of this particular meeting, the best of this academic feast. Let us all join together and enjoy. Welcome to one and all. Thank you, and over to Dr. Dharminder. Please go ahead with the proceedings.
Thank you, sir. Thank you for your kind words, and you are always a guiding light. So, without wasting the time, I should transfer this to Professor Mahesh Prakash. He did not need an introduction. He is the founder member of Muscular Society of India, and by Professor, it might look that Dr. Mahesh Prakash is old, but day by day he's becoming young. That's why he's the moderator of the Voice of Young MSS. So, Mahesh Prakash, sir, are you ready to? Yeah.
Thank you. Thank you. Good morning, everyone. And thank you, DK, Dr. Govindraj, MSS, and for this wonderful meeting. And as you said, that probably this is a wonderful thing, like we are dealing with one of the important joint, that is the ankle joint. And I will say that these speakers are not only the young, but the next generation enthusiastic, the faculty. And we are very, very confident that they are doing wonderful work in their field. And so without wasting time, so go to the first speaker. Can we have the first speaker?
Dr. Harsha, kindly share your screen.
So, first speaker is Dr. Harshvardhan KR, and presently he is a senior consultant and HOD in SSI HMS Puttaparthi, AP. He's an ex-assistant professor of NIMS, Hyderabad, and his interest in MSK and cardiac imaging. He has a lot of the the lectures in national international conferences. His publications more than 20, and he has a co-authored in various the book chapters. So over to Dr. Harsha. Please share your screen and go ahead.
Dr. Harsha, kindly unmute yourself.
Am I audible now?
Yeah. Yeah.
Hello, Ram. Hello.
You are audible now. You are audible now.
Yeah. Well, thank you very much, Mahesh sir, for that kind introduction. And at the outset, I would like to thank the organizers of this new trend of webinar for giving me an opportunity to talk about the normal anatomy of the ankle here, and also Dr. Ramakrishna for technical support. So ankle joint is, as we all know, the ankle joint is a synovial hinge type of joint, which is having a slightly complex anatomy because of its ligament and the tendon attachments. So this is this ankle joint is formed by three main bones. That's the tibia, fibula, and the talus. So arbitrarily, we can add the calcaneum and the talus to the list as it articulates with the as these bones, the calcaneum and the navicular bone articulates with the talus. So before going for the anatomy, the first and foremost important point to be remembered or revised is the ossification centers of this ankle joint. Why? Because this is very important in pediatric trauma settings. So often it gets confused with the fractures. So three ossification centers are described for this ankle joint, and one for the distal fibula, which appears in 6 to 12 months and fuses by 17 to 18 years. One for the medial malleolus, which appears by 7 to 10 years, and another for distal tibia, which appears in 4 to 12 months of the age, and which fuses 17 to 18 years. So totally, by the age of 18 years, all these ossification centers should fuse with the native bone. So the fusion of this distal tibia, which occurs from the medial to lateral pattern. So as the age increases, the fusion is increasing from medial to the lateral. So by the age of 7 to 8 years, entire physis and the ossification centers should close to the native bone. The major movements or motion at the ankle joint are the abduction, adduction, plantar flexion, dorsiflexion, inversion, and then eversion movement, and also the pronation and the supination motion. These are the major movements we can see across or see at the ankle joint. So the modalities which are available for us is the radiography, the ultrasound with Doppler, which is very helpful in not only in diagnosis but also in therapeutic conditions. Other modalities, the CT scan, MRI, MR arthrography, DSA, and nuclear scans. Today, we're not going to discuss about the DSA and nuclear scans. So I will be more concentrating on the ultrasound and the MRI. Like any other joints, ankle joint also should be assessed from the bones, cartilage, synovium, tendons with corresponding muscles, ligaments, neurovascular bundle, subcutaneous pad, and up to the skin surface. So coming to the radiography of the ankle joint, so we have a set of views for the ankle joint to see anatomy, and they are the anterior-posterior view, mortise view, lateral view, oblique view, stress view, and other views depending on the indication. And again, the detailed technical aspects and the lines which are described with the ankle joint are out of scope of this talk today. So in brief, this is how anterior-posterior view of the ankle joint appears. You can see the tibia articulating with the talus, and this is the fibula, and medial malleolus and the lateral malleolus. And the lateral view, we have to see to that the distal end of the fibula overlaps the tibia, and the other bones to be included in the lateral view are the calcaneum, navicular, cuboid, and base of the fifth metatarsal bone. The other views are the mortise view, oblique view, and stress views. The mortise view is usually seen for the articulation of this ankle joint, the tibia with the talus. So it usually corresponds to the mortise here. Like in the carpentry, you can see this is the mortise which is formed by the distal end of the tibia, and the tenon is formed by the dome of the talus. In oblique view, we have to look for the tibiofibular joint space. Usually the normal diameter is up to 5 to 6 mm. If it is beyond, we have to suspect any syndesmotic injury or a ligamentous injury at this particular joint. And the stress views are usually asked for any alignment and to see this other pathologies. Coming to the approach, like any other joint, ankle joint also should be approached using a mnemonic, very simple mnemonic, ABCDES. It stands for alignment, bone density, cartilage, dissection, erosion, and soft tissues. So if you have a systematic approach, you will come to some conclusion and you can access and then you can establish a good diagnosis. So a word about the accessory ossicles around ankle and foot. Nearly 40 accessory ossicles has been described in the literature. It's difficult to remember all the accessory ossicles, out of which if you remember, a handful of the numbers is more than sufficient. And out of these also, some 4 to 5 are very important, which you come across daily, in a daily practice routine practices. Coming to the approach and the checklist for the ankle joint. So arbitrarily, this can be divided into anterior, posterior, medial, lateral, and inferior compartments. So once you decide these compartments, then you should have a checklist for all the compartments, what to look for, what not to look for. And if you follow this checklist, it is very helpful in coming to one conclusion and then identify the pathology. So these are the structures which you have to look in the anterior compartment, and the posterior and inferior compartment. These are the structures you have to look. Coming to the medial aspects, these are the structures, and the lateral structures, and these are the structures. And inferiorly, you have to see for plantar fascia. So I'll be coming across all these structures in detail. After assessing these compartments, then you have to see for the muscles, neurovascular bundles, and skin and subcutaneous planes around the ankle joint. So CT scan usually is not the preferred technique or modality at the beginning, but sometimes to pick up any minute or minor injuries, these are indicated and suggested for the patient. So again, this is the axial and coronal reformatted CT scan of the ankle joint. You can see all the tibia, fibula, and the talus bone. So in this case of a 14-year-old patient, we didn't find any fractures, but then we found a very important accessory bone, that is an accessory navicular bone, which is embedded in the posterior tibialis tendon. Coming to the ultrasound, so these are the main the schematic diagnostic picture where you can see the positions of the probe. You can see for the anterior compartment, the lateral compartment, the posterior compartment, and the medial compartment. So we'll go one by one. Coming to the anterior aspect, the probe, this is the position of the probe to see if the predominantly the ankle joint, the tibio-talar joint, and the talonavicular joint. So this is the distal end of the tibia, and this is the talus articular surface. You can see this the joint space. This is the place where you have to assess for the joint effusion, synovial thickening, or any increase in vascularity of the synovium. And also you have to look for the fat pad which is anterior to the talus. If this fat pad is disrupted, then you can think of any pathologies. So one important structure in the anterior is the anterior tibiofibular ligament, which is the syndesmotic ligament which connects the tibia and distal tibia and the fibula. The position of the probe should be like this, and the foot you can give a small towel or a pillow under the middle malleolus, and then you can put a probe and then see the image like this. So this is the distal end of the fibula here and the tibia. A band which is connecting these two is the anterior tibiofibular ligament. Coming to another important ligament in the anterior compartment is the anterior talofibular ligament. As the name suggests, it connects both the talus and the fibula and the distal end of the fibula. Again, this is the position of the probe here. You can see you have to place the probe obliquely from the lateral malleolus, and then you have to look for a band of the band-like structure which connects the fibula and the neck of the talus. So here in this case, in this picture, in this image, this is the band which is connecting the fibula and the neck of the talus, and this is the anterior talofibular ligament. And this another image of the talo anterior fibular ligament, which is outlined by the color coding here. And this is the weakest ligament in the ankle, where you can expect the injury or a tear even in a small minor trauma. Another ligament in the anterior aspect is a dorsal talonavicular ligament. So as I previously said, you have to keep the probe portions and then look for these structures, the tibia, the talus, and the navicular bone. The band which is connecting here is connecting the talus and the navicular is the dorsal talonavicular ligament. Another important structures in the anterior compartment is retinaculum. So this is there are two types of retinaculum are present, with this like superior retinaculum and inferior retinaculum. Superior retinaculum is usually seen 1.5 to 2 centimeters proximal to the distal end of the tibia, and it is holding these the tendons which are very important in the anterior compartment. The inferior retinacula has a Y-shaped band which is seen in the at the level of the sinus tarsi. You can see it is holding off this tendons, and this image you can see here is a extensor digitor longus tendon with the reflection of the retinaculum here. So this is you have to see the retinaculum like this and then assess. The other important structure is the tibialis anterior tendon in the anterior compartment. So this is the position of the probe to look for the anterior tibialis tendon. Once you localize this tendon, you have to sweep your probe throughout the course of the tendon. One important point is when you are tracing the tendons and the nerves, you have to trace till end. That means the tendon should be traced from the myotendinous junction up to the insertion site. That is a dictum in doing ultrasounds of these tendons and nerves. So this image you can see this is the tibialis anterior tendon, which is overlapped by the superior retinaculum here. Other two important tendons in the anterior compartment are the extensor hallucis and extensor digitorum. Extensor digitorum longus tendons, which are placed lateral to the tibialis anterior. So in this image, your probe should be little lateral and anterior to sweep from the top to bottom to look for and trace for these tendons. That is anterior tibialis anterior tendon, extensor hallucis longus tendon, extensor digitorum longus tendons. Important nerve in the anterior compartment is a deep peroneal nerve, which usually courses along the anterior tibial artery in the distal leg, which lies medial to the anterior tibial artery. As you sweep the probe at the level of the ankle joint, it switches from medial to the lateral aspect. So that's very important to identify this deep peroneal nerve on ultrasounds. Coming to the lateral compartment, three structures which has to be very well assessed is the peroneal tendons, peroneal retinaculum, and the calcaneofibular ligament, which is the lateral stabilizer of the subtalar joint. So this is the probe position. You can see there's the two tendons. What we are observing here is the peroneal tendons. So this is the distal end of the fibula here. So how to identify these two tendons is very simple. The one which is very close to the bone is the peroneal brevis tendon. You can also remember B for B. So B for bone for brevis, and the one which is away from the distal fibula is the peroneus longus tendon. Once you identify these two tendons are held together in position of the posterolateral groove by a retinaculum overlying to this, which is attached to the fibula, and in the superior aspect. And as you trace down at the calcaneum, another peroneal inferior retinaculum is seen. That's the inferior peroneal retinaculum at the level of the calcaneus. So these two are this peroneus brevis and peroneus longus tendons. As I said, it has to trace till the insertion of those tendons. Another the important ligament in the lateral compartment is the calcaneofibular ligament. So this is a position for this the position of the probe for the calcaneofibular ligament. So you can see the distal end of the fibula and the calcaneum. Usually the proximal end of the ligament which arises from the distal fibula is difficult to appreciate on liver, difficult to appreciate on ultrasound, and once you see band-like structures deep to the tendons and then going up to the tubercle of the calcaneum, that forms the calcaneofibular ligament. Another image which is showing the calcaneofibular deep to the peroneal tendons and which is overlapped by the peroneal retinaculum here. So this is the tubercle of the calcaneum where this calcaneofibular ligament gets inserted. The important, another important nerve in the anterolateral aspect is the superficial peroneal nerve, which usually emerges out of the facial planes to the subcutaneous planes at the distal leg, where it is the point for a point of entrapment of this nerve, and this needs to be traced. And if you trace in the subcutaneous planes, this nerve the nerve appears like this, and this is the longitudinal entire length of the superficial peroneal nerve. It has to be traced. Then coming to the medial compartment, in the middle compartment we have the tarsal tunnel. It's a fibroosseous tunnel which contains the flexor tendons, vessels, and the tibial important tibial nerve. So this is the position of the probe for the tarsal tunnel. You can see the main tendons like from the anterior to posterior, tibialis posterior, flexor distorum, flexor hallucis. So in between the flexor distorum and flexor hallucis is the posterior tibial vessels and the tibial nerve. So while you are tracing the two tendons of flexor distorum longus and flexor hallucis longus, you come across a point where these two tendons cross each other at the level of the posterior arch, and that crossover point is known as master knot of Henry, and which is a very important potential space for intersection syndromes, which can cause tendinitis or tendinopathies of these two tendons. So you can see this is the crossover of these tendons. Another image depicting the entire tarsal tunnel. You can see the flexor retinaculum is covering the tarsal tunnel here, and the tendons from anterior to posterior. In between these two tendons are the vessels and the nerve. Coming to the very, very important and complex ligament in the medial compartment is the deltoid ligament, which has 4 components, that is posterior tibiotalar ligament, tibiocalcaneal ligament, tibionavicular ligament, and anterior tibiotalar ligaments. So this is the first component of the deltoid ligament. You have to place the probe a little bit posteriorly from the medial malleolus in oblique fashion, and we have to check for see for the band which connects the tibia and talus. That band forms the posterior tibiotalar ligament. Another slightly anteriorly is the tibiocalcaneal ligament. So you can see the previous ligament was like this, and this is just like this. The probe is a little bit anteriorly, and this is the ligament which is connecting the tibia and the calcaneum. You can see this is the tibia, this is the talus, and the callus, the band which connects this two bones, is the tibiocalcaneal ligament. So the tibionavicular ligament, the third component is the tibionavicular component. This is slightly obliquely anteriorly placed like this compared to this the previous ligament. So if you observe, so you have to fix your point the medial malleolus of the one end of the probe, and then the other end should be fanned around to look for the deltoid ligament components. And this ligament is the tibionavicular ligament, which connects the tibia and the navicular bone. Another small important fourth component is the anterior tibiotalar ligament. As the name suggests, it connects tibia and the talus. You have to place your probe like this at this level of the medial compartment, and then you can see a band of this structure which goes like this. That's the tibiotalar ligament. Another small important ligament which is technically challenged for the beginners to look for is spring ligament, that is the calcaneonavicular ligament, which where it is connected between connecting the calcaneum and the navicular bone. The calcaneum and the navicular bone. You have to place the probe little bit inferior aspect of these infero-anterior to the medial malleolus, and then look for the band which is connecting the talus head and the calcaneum. This is the superomedial aspect of the spring ligament here. The important nerve which is in the middle compartment is a tibial nerve, which usually courses between the flexor distorum longus and hallucis longus, and divides into the plantar nerve and the medial calcaneal nerve. The medial plantar nerve again divides into two structures, that is medial plantar nerve and the lateral plantar nerve. The lateral plantar nerve inferiorly, when it is coursing, gives rise to an inferior calcaneal nerve, which is known as the Baxter's nerve, and this is the potential nerve for pathology. It can undergo neuritis and neuropathy and gives a chronic heel pain. So this is the image which is showing the posterior tibial tendons and the nerve which is the tibial nerve, which is divided here into the medial calcaneal nerve, and the plantar nerve is not shown in this image. So you have to trace this and then see for the nerves. Coming to the posterior compartment, the two structures we can see is the Achilles tendon, sometimes the palmar longus tendon. And the main position for the assess the Achilles tendon is patient should be in the prone and the ankle should be hanged at the edge of the table like this, and then you can assess the Achilles tendon like this. So this is the panoramic view of this Achilles tendon, where you are seeing the entire length of the tendon which is getting inserted under the calcaneal. You can clearly see this is the calcaneal, and this the potential, the space between this tendon and the calcaneal surface is the retrocalcaneal bursa, and the anterior to it is the Keger's fat pad. So you have to look for all the pathology. This is a normal Achilles tendon with retrocalcaneal bursa and Keger's fat pad. The plantar fascia is assessed like this. In this pattern, you have to first look for the calcaneal surface, where from the plantar fascia attaches this. This is the insertion site of the plantar fascia to the calcaneal. Once you identify this, then you can. It's easy to course this plantar fascia up to this distal end, and you have to assess for the insertion site any abnormal altered ecotexture or increased vascularity to call for the plantar fasciitis. So this is the next coming to the MRI. This is the major protocol for MRI ankle joint. You can add on the sequences like depending on the pathologies. So once the MR images, if you open, so you have to place all the plane images in one screen, so that you screen all the structures in 3 planes. For example, this is the PDFS sagittal, and then the PD axial images, and then PD fat coronal images. So once you identify the alignment and signal intensities of all the bones, joint spaces, and articular surfaces, you have to come for the you have to next assess the compartment device. So at the anterior compartment, where you can see this talonavicular ligament, dorsal talonavicular ligament, and then the tibiotalar joint for the synovium and synovial fluid. So a trace or minimal of fluid in the joint space is almost most of the cases we see, but if you see a pathological, you should see the bulging of the synovium or thickening of the synovium for the pathologies. So as I said, this is the axial PD sections. You can clearly assess all the structures in this, coming for assessing the ligaments like anterior tibiofibular ligament, posterior tibiofibular ligament, and the syndesmosis. And then is even more little, you can see this anterior talofibular ligaments. And posterior talofibular ligament, anterior talo, and this is the posterior talofibular ligament, which is assessed both in the axial and as well as in the posterior planes, posterior coronal plane images. And after coming to the anterior compartment, then you have to come to the medial compartment. You can, as I said, like you can assess for all the tendons. This is the tibialis posterior, flexor distorblax, and flexor hallucis longus tendons. So you have to scroll through all the images and then see for the T up to the insertion site. And this is tibial vessels, and this is the tibial nerve. So you can follow that into division, which is dividing into this nerves, which I have already explained. In the posterior compartment, again, you have to look for the tibialis Achilles tendon for its normal structures, and in the lateral compartment, as I said, to assess for the peroneal tendons, which is covered by the peroneal retinaculum here, and among the 2 tendons, the one which is closer to the bone is the peroneus brevis, and this peroneus longus tendon. So you have to scroll through and then assess all the images up to the insertion site. Another important structure in the lateral compartment is the calcaneofibular ligament. So if you see here, this is that attachment where you can see the calcaneofibular ligament to the fibula, and then I'm scrolling it down. If you see, this is the band which is coming like this, and then attaching towards the tubercle of the calcaneum here, and that's the calcaneofibular ligament. And again, one more thing is that deltoid ligament is the one which is usually assessed in the coronal planes and the axial planes very well, so that we can see some of the pathologies of this deltoid ligament. So you can see, so this is the components of all the 3 of deltoid ligament here. And another images are other images are the PDFS coronal and the PD coronal images. So another set of images will be kernel T1, so that you can, T1 is one sequence where you can see all the ligaments very well if it is very normal, and this has to be correlated with this fat site images of PD or PDFS or raster images to look for the pathologies. The word about MR arthrogram, this is the site. The site for MR arthrography is the site of injection is medial to the tibialis anterior or just lateral to the tibialis anterior. And it is usually done under fluoro or ultrasound. Ultrasound guided is suggested because we can avoid injury to these tendons. Once the needle tip is in between the tibia and the talus, so you can inject this mixture of this contrast. After injection, immediately you have to scan the patient within 20 to 30 minutes of the injections, and the preferred sequence is T1 with spin echo and without with and without fat saturation. And the image which looks like these are the images which looks like MR arthrographic images. You can see all the contrast which is surrounding the structures. The main indications for this MR arthrography is ligamentous injuries, ankle impingement syndromes, osteochondral and cartilage lesions, intra-articular loose bodies, and adhesive capsulitis. These are the main indications for MR arthrography. And for a normal man, if he sees this kaleidoscope, usually you see the normal colors like this. But if a radiologist sees a kaleidoscope of the ankle, usually he sees this, or this, and finally gives a diagnosis of the disease. And to conclude, never do an ultrasound or read an MR or CT without reading a radiograph of the ankle joint. As I said, systematic approach is required for analysis of any disease or pathology. And one should have a checklist and then follow the checklist not to miss any structure in the report structures, and give a structured report and suggest or guide what next to be done for the coming to the confirmation of the diagnosis. And for the beginners, I would like to recommend this book to have a formatted or a structured report where you can see all the points in that report. And thank you. This is the hospital where I'm working. And anybody who is visiting Puttaparthi, please come to the department. All are welcome. And Sai Ram.
Thank you. Thank you, Dr. Harshvardhan, for the detailed anatomy, not only the radiograph, but the ultrasound as well as on MRI. So thank you very much. And I don't think we are having any questions, but I'll just ask you one question. What is nowadays the indication of MR arthrography in the ankle in your clinical practice?
I have not got any personal request, but it's described in the literature. Just I included in the talk.
Good. Thank you, Dr. Harshvardhan. So
thank you.
We'll move. Thank you. So we'll now move to the next speaker, and next speaker is Dr. Chaitali. Dr. Chaitali, can you project your slide? Chaitali, you are there?
I'm just waiting.
Okay. Sure.
Okay. I think it's visible, sir.
Dr. Chaitali, can you make it the full slide view, please?
Yeah. I hope it's visible.
Yes, Dr. Chaitali, it is visible.
Okay.
Mahesh sir.
Me now?
Yes, sir.
Okay, sure. So the next speaker is Dr. Chaitali Parikh, and she's the consultant interventional MSK radiologist, and she's working in the Pulse Change of Diagnosis Center, and she is the director of the Joint Ultrasound Intervention Clinic, Mumbai. And as written that she's a passionate traveler, and she has traveled a lot of the country, even somebody can think in the whole life. So, and she's done the fellowship in MSK Diagnostic Intervention Radiology from Innovation Imaging. She's received Chairman Appreciation Award at IRA Amritsar. She has received R.N. Goel Award Medal, and she has a guest speaker on various national conferences, and she has a big the achievement and the big CV. So I'm not going to detail to you. And thank you, Chaitali. and she will be speaking with a very, very important topic we usually come across in the clinical practice is the anterolateral instability of ankle. Over to you, Dr. Chaitali.
Thank you so much, sir, for this wonderful introduction. And at the outset, I would like to thank Dr. DK Singh, sir, Dr. Mahesh Prakash, sir, Dr. Jairaj, sir, for this wonderful opportunity. Dr. Ram, sir, for making this whole process very smooth and for all the technical support. And all the speakers for giving time on this Sunday morning and sharing knowledge with everyone. So thank you so much, everyone. Without wasting any time, I'll just start with the session. So as sir already said, I'll be discussing on anterolateral instability. So firstly, I would like to thank Dr. DK Singh, sir, because most of the ultrasound images in my lecture on my talk has been provided by him. So thank you so much, sir. So already what we're going to discuss is normal anatomy has already been discussed. We'll be mainly concentrating on the abnormal appearances of these ankle ligaments. What happens when your ankle twists? Do you always need an imaging in an ankle sprain? What are the imaging findings in an acute ankle sprain? What is the difference between low versus high ankle sprain? What is chronic lateral ankle instability and what is anterolateral impingement? So the last two things I would just be covering very briefly, but we'll be concentrating on the rest of it. So again, you know that there is a low ankle ligament, there are high ankle ligaments, and then another structure that is important is anterolateral capsule. So we look at each of these individually in the next few slides. So what happens when your ankle twists? Now, there are three types of sprains that usually happen, of which the lateral ankle sprain, the lateral low ankle sprain is the most common type, which is actually a forceful inversion injury in a plantar flexed foot. So whenever you stamp your foot and your foot is in a plantar flexion, there are chances that it can go into inversion, and that is what happens in the lateral ankle sprain. For the medial ankle sprain, it's a forceful eversion injury, which will be discussed ahead in today's lectures by someone else. And then you have a high ankle sprain, which is an external rotation and a dorsiflexion. So this is predominantly a dorsiflexion, and this is predominantly in a plantar flexed foot. Now, what is the most common mechanism? So this is mainly for your low ankle sprain, where you have an inversion injury in a plantar flexed foot, as I already told you. If you try actually to, just plantar flex the foot, all of you just try plantar flexing a foot and try inverting it afterwards. You will feel a stretch in your lateral ankle ligament. So that is what happens. So whenever it goes into inversion, there is a stretch on the ligaments, which can result into injury or tear. Now, the body has a mechanism that if you are falling or if something is going out of the way, it will try to bring it back. Now, that thing is done by your everters of the foot, which are nothing but your peroneal tendons. If these everters so what happens is these everters of the foot fire forcefully to bring your foot back into neutral position. And what happens because of that, sometimes the force is so forceful that even your peroneal tendon gets injured, mainly your peroneus brevis, and or it can be a avulsion fracture at the base of the fifth metatarsal. Along with that, the superior peroneal retinaculum also gets injured, which is actually holding the peroneal tendons in the groove. Okay, so this is just an animated thing to explain what exactly happens when your ankle twists. And I'm sure most of you already know what happens because most of you have got at least one ankle sprain in your life. So it's a very common ankle sprain. I'm sorry, someone has, yeah, okay. So, so what happens is this is your medial side. So there is going to be an inversion of the foot. So whenever there is an inversion of the foot, your talus, calcaneum, and your foot, they're going to go medially and in inversion. As a result of which, there is tear of the lateral ankle ligament. So this is your anterior talofibular ligament, which is ATFL, and this is a calcaneofibular ligament, which is CFL. So now there is a tear. Now, if you notice one thing, there is an impaction between the medial dome of talus and the tibia, as a result of which you can develop marrow edema or even osteochondral lesions in the talus because of this impaction. Now, what happens is your peroneals will come into the picture. They will try to fire and get the foot back in neutral position. So eventually, when you image the patient, what you see is marrow edema in the medial dome of talus, sometimes also in the medial aspect of tibia. Then there can be an osteochondral lesion in the medial dome of talus, and obviously you will have injured lateral ankle ligaments. Besides that, as I said, if the peroneal fires very forcefully, then you can have peroneal tendon or superior peroneal retinaculum injuries or even avulsion fractures. So one thing is most of you would have got an ankle sprain, but how many of you have actually done an ultrasound or an MRI for an ankle sprain? So we don't do it, right? So when is it that you actually need an imaging? When the pain and swelling is not subsiding even after 1 or 2 weeks of rest. So normally what we do, you put a crepe bandage, you do rise, you elevate your leg, but still if it's not subsiding, you would want to get an imaging done. If the pain and swelling is too much than expected for an ankle sprain, meaning the orthopod or the clinician is thinking in terms of a severe sprain where there is a complete tear of ligaments or there is an associated fracture. In chronic ankle pain and instability, to understand what is the status of the ligaments and if there is any arthritis, and suspected if a high ankle sprain is suspected on clinical examination. So in acute low ankle sprain, what happens is the low ankle ligaments are injured. Meaning you can also get injury of the medial ligament, but today, right now, we are only concentrating on the lateral ligaments. You can see fractures, so there can be ligament avulsion fractures or tendon avulsion fractures. You can see lateral marular fractures. We'll discuss this in detail in the next few slides. And then there can be even anterior calcaneal and lateral talar process fractures. You know the mechanism why the talar osteochondral lesion happens. And obviously, as I've discussed, peroneal tendon and retinaculum injuries. Now, as already discussed, the 3 most common modalities that you use for any ankle imaging is your radiographs, ultrasound, and an MRI. MRI with or without arthrogram, depending upon the personal choice as well as choice of your referring clinician. So soft tissue ligament injuries, what do you see? So in a radiograph, obviously it is difficult to see any soft tissue ligament injury unless there is a fracture. But the most common finding that you'll see in a patient with ankle sprain or a recent ankle twist is swelling, soft tissue swelling along the lateral aspect of ankle. So if you do not see a soft tissue swelling, that does not mean that the patient does not have an ankle sprain. It just means that the soft tissue swelling is not that much that it can be seen on a radiograph. MRI is obviously the best modality to look at the whole picture of the ankle, where you can evaluate your tendons, your ligaments, your cartilage, everything, and your retinaculum as well. So this is your anterior talofibular ligament injury spectrum. So where this is actually a low-grade injury. So what you see is there is some hyperintense signal within the ligament. There is some soft tissue edema and fluid around the ligament, but there is no tear of the ligament. So this is a low to intermediate grade injury. Here you can see the fibular attachment is good, but at the talar attachment, there is partial thickness tear. So some of the fibers are still attaching to the talus, but some of them are torn. So this is a partial tear. And here you can see there is a clear bright signal. So this bright signal is almost similar to the signal of the fluid in the joint. So whenever you see a fluid signal intensity between the ligament and the bone, you know that it's a tear. And this is a full thickness tear of the ATFL at the talar attachment. Ultrasound also gives you a very good imaging for low ankle ligaments. So this is your normal ATFL. This is a thickened ATFL, but you cannot appreciate a discrete tear in the ligament fiber. So it's more like a sprain of the anterior talofibular ligament. Here, if you closely appreciate, just appreciate the thickness of the ligament at this attachment. This is the fibular attachment. And at the talar attachment, you can see that there is thinning of the ligament. So it's a partial thickness tear at the talar attachment of the ATFL. And here you can see this hypoechoic to anechoic area. This is nothing but fluid. Why? Because there is a full thickness tear of the ligament from the bony attachment, and as a result of which there is fluid in this region. So this is a high grade to full thickness tear of the ligament. Now, similar spectrum you will find for all the ligaments. Your low ankle, your high ankle, your medial ligaments, all of them on imaging will appear the same. So this is an intermediate grade injury where you can appreciate that the fibers are reaching up to the fibula, but they are hyperintense. You cannot really appreciate the individual fibers well. So it's not a tear, it's a sprain, but it's an intermediate grade sprain. Here you can again see there is a nice bright signal over here. And if you appreciate on the FS image, you can see this white. This white is just similar to the fluid signal intensity. But you can appreciate that few of the fibers proximally and distally are reaching up to the calcaneum. So this is like a partial thickness tear at the calcaneal attachment of CFL. And this is an intermediate grade injury at the fibular attachment of CFL. Same again on an ultrasound, you can appreciate the normal CFL. This is a partial tear mainly along the undersurface and some intrasubstance tear. And here you can see that there is a lot of fluid, so there is no ligament. This is your retracted ligament over here. It is not reaching up to the bone. So this is like a full thickness tear of the CFL from the fibular attachment. Now, as I said, not only soft tissue injuries, the ligament can also cause avulsion fractures. Avulsion fractures can obviously be very well picked up on a radiograph. So here what you see is a nice fracture at the tip of the lateral malleolus. If you can appreciate, just look at nicely the fat over here. You can see that there is some increased density. So this is some soft tissue swelling over here. So this is nothing but your ATFL avulsion fracture. There is no widening of the syndesmosis, which means that chances of high ankle sprain are less. It doesn't mean that there are no chances of high ankle sprain, because not all high ankle sprain will cause a widening of the syndesmosis. So then this is obviously a MR image where you can see there is a high grade injury of the ligament, but along with that, you can see that there is a avulsed bony fragment, which is non-displaced. So this is a avulsed fracture at the fibular attachment of ATFL with adjacent moderate to marked marrow edema. Now, talar osteochondral lesion, as we know that the medial dome is going to impact against the medial tibia. Again, talar OCDs are difficult to pick up on radiograph because most often they are quite subtle. But if you look at them very closely, you will not miss it. So important is to know the history. If you know that the patient had an ankle twist, you will obviously go and look out for it. So here you can see there is a nice radiolucent line that is going. And you can see there is some kind of cortical breach over here. So this is nothing but your non-displaced talar osteochondral lesion. Similarly, on an MRI, you can see that this entire thing is an osteochondral lesion. One more thing that you can appreciate is you can see nicely this gray zone. So this is the cartilage of the tibiotalar joint. Here in this region, you can appreciate that the cartilage is hyperintense. There is some fraying. So it is mildly bulky, hyperintense with some fraying. Also, this is the fat saturated image of the same patient. So you can see this hypointense line indicating that it's an osteochondral fracture. And here you can see that there is the cartilage is again slightly hyperintense. So there is some softening and fraying of the overlying cartilage. So this is nothing but the osteochondral lesion. Now, tendon and retinaculum injuries. Fifth metatarsal base fracture, avulsion fracture is what commonly happens in terms of tendon injuries. This is what you see with the peroneus brevis tendon avulsion. So again, you can appreciate it on an MRI. You can see that this is a non-displaced fracture of the fifth metatarsal base, exactly where the peroneus brevis is attaching. And here also you can see this is the fracture and this is your peroneus brevis which is attaching. If you'll appreciate, there is some hyperintense signal within the peroneus brevis also. Obviously, there is magic ankle artifact that happens in peroneus brevis tendons, but usually you do not see that magic ankle artifact at the insertion. So insertion here, you can see that there is bright signal, which means that there is contusion along with peroneal tendon osseous avulsion. Now, the next thing is superior peroneal retinaculum. So here, this is a normal retinaculum. You can see this nice thin band that is going over the peroneal tendons in the retromalleolar groove. So this is the superior peroneal retinaculum. Here you can see this retinaculum is nice on the medial aspect, but on the lateral aspect at the fibular attachment, it's thickened. So this is the injury of the retinaculum. Here there is a complete tear of the retinaculum from the fibular attachment, and you can see that the peroneal tendons are subluxating out because the structure which was holding them behind is no longer intact. And here you can see that there is injury of the peroneal retinaculum, but along with that, there is a longitudinal split in the peroneus brevis tendon. So as peroneus brevis fires, sometimes it is common to see that there is a longitudinal split that happens within these tendons. Now, what are the other associated fractures? So as I said, you have the anterior calcaneal process fracture. Now, anterior calcaneal process fracture is one such thing which is more easy to pick up on a radiograph because you get this lateral view very nicely. And they are sometimes missed on an MRI because if you don't have a lot of marrow edema and if the fracture is not displaced, it is often missed on an MRI. So that's when your radiographs really help you to pick up these fractures. Weber type A fracture. Now, what is a Weber classification? So Weber classification is for lateral malleolar fractures, wherein if the fracture line is below the level of syndesmosis, so this is the tibiofibular syndesmosis. So if it is below the level of syndesmosis, it is type A. If it is at the level of syndesmosis, it is type B. And if it is proximal to the syndesmosis, it is type C. Type B and C are often associated with high ankle sprains because you are at the level of syndesmosis and above. Type A is associated with low ankle sprain because you are below the level of syndesmosis. So this is a Weber type A fracture and a corresponding MRI image as well. And the last thing is the lateral talar process fractures. Now, lateral talar process fractures are often difficult to pick up on radiograph. If you have an oblique view, they are very well seen on that, but it is sometimes difficult to pick up on X-rays, but they are very well seen on an MRI. So this is just a gist of what we've discussed. Most of it is just common sense. Just remember, anterior calcaneal process fractures can sometimes be missed on an MRI, so radiograph can be helpful. So this is one thing that I want you to concentrate on. Now, we've discussed high ankle sprain. Now let's discuss the low ankles. We've discussed low ankle sprain. Let's discuss the high ankle sprain. It is nothing but the injury of the syndesmosis, the distal tibiofibular syndesmosis. And the ligaments are your anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament, and your interosseous ligament. Widening of tibiofibular syndesmosis is something that is very important, because if it is there, they'll consider surgical management, and they're associated with Weber type B or C fractures. So again, on radiographs, what you'll see is the widening and the fractures. On MRI, what you'll see is the ligament injuries, and obviously you can also see the fractures on MRI. So here what you see, this is so we've seen type A fracture, which was somewhere at this level, where you can see this fracture. So this is a syndesmotic level, and you can see that the fracture is actually at the level of syndesmosis. So this is nothing but the Weber type B fracture. And here you can see this is slightly proximal to the syndesmosis, and so this is your type C fracture. Similar corresponding images, this is your type B fracture, where you can see that this is your level of anterior inferior tibiofibular ligament. This is your interosseous ligament, and you can see that the interosseous ligament is actually injured and there is edema in this region. Here, this is a type C fracture, which is slightly above the level of syndesmosis. Now, the ligament injuries, AITFL is the most common ligament that gets injured in a high ankle sprain. So this is a high-grade injury where you can see that the fibers are going across. There is no clear-cut fluid signal. Okay, but you actually cannot appreciate, and the ligament itself is very thick. So you know that it's a high ankle injury, high-grade injury. And here now this is a full thickness tear at the talar attachment of AIT, at the tibial attachment of AITFL, where you can see a proper fluid, and you can appreciate the fibular attachment. And this you can appreciate that the tibial attachment of the ligament is intact. This is your ligament over here, and there is an avulsion fracture at the fibular attachment. So this is nothing but the avulsion fracture of the AITFL. Again, on ultrasound, this is your normal AITFL. This ligament is very well and very easily seen on ultrasound. So this is a normal AITFL. And here you can see that at the fibular attachment, there is heterogeneous appearance. There is some fluid intensity. So this is nothing but your high-grade injury. Now this is your PITFL. So it is seen nearly at the same level as your AITFL. So this patient had a high-grade, had a full thickness tear of the AITFL and a low to intermediate grade injury of the PITFL. Now let's look at the interosseous ligament. Now this is your interosseous ligament. This is your interosseous ligament. Normally in the distal tibiofibular syndesmosis, what you see is fat. So it should appear hyperintense on your fat saturated images. This some amount of hyperintensity or fluid that you see in the distal most part is actually the normal joint recess. So if you see this picture, this should not be mistaken for any syndesmotic injury. Here what you see is there is a Weber type B fracture. What you can see is there is lot of edema in the syndesmosis, and this is your interosseous ligament. So what you see, the fibular attachment is nice and thin, but the tibial attachment is thickened. Here what you see is a full thickness tear of the syndesmotic ligament with fluid signal and a lot of soft tissue edema in the syndesmosis. Now, what happens? Now, this is a low ankle sprain where there is a obviously ATFL avulsion. So you know that this is a low ankle sprain. Why am I saying low ankle? Most likely because there is no widening of syndesmosis. There is a tibiofibular overlap. Whereas here you can see that there is loss of tibiofibular overlap and there is obvious widening of the syndesmosis. So this, you know that it's a high ankle sprain. In this patient, again on an MRI, MRI is not the modality for saying about widening of syndesmosis, but if it's obviously widened, you can put it in the report. So here you can see nicely your interosseous ligaments and a normal syndesmosis. Here you can see that the interosseous ligament is disrupted, it's thinned out at the tibial attachment, and there is obvious widening of the syndesmosis. Now just a quick run through of what is chronic ankle instability. Obviously, it is nothing but recurrent ankle sprains. It is important because it will affect the quality of life. It can cause ankle impingement, and most importantly, it will result into osteoarthrosis. So this is a whole list of findings that you get. In short, It is nothing but the chronic version of acute injuries and changes secondary to osteoarthrosis. So here you can see a nice thick ATFL with a partially united fracture. So this is a well remodeled one. Here the talar attachment is good, but you can see fibers reaching up to the fibular attachment, but there is some hyperintense signal. So this is partially remodeled. Here you can see that there is a lot of hyperintense signal. You cannot appreciate the individual fibers distinctly. This is poorly remodeled. And here you can see the ligament, but is markedly thinned out. So this is a patient with chronic ankle sprain where the ATFL is now completely thinned out and functionally not viable. Obviously, you get OCDs, so you can see chondral changes which are further progressing because of instability, and eventually they'll result into tibio-talar OA. Advanced patients can also develop subtalar osteoarthrosis. Now, one last concept is anterolateral impingement. So this is your AITFL, this is your ATFL, and the image between these two, what you see is a thin black structure, which is nothing but your anterolateral capsule, which is overlying your anterolateral cutter. So this fluid area is the anterolateral cutter, overlying is the anterolateral capsule. Here you can see that there is a soft tissue thickening in the region of the capsule, which is kind of partially effacing the anterolateral cutter. Here you can see that there is an osseous body in a patient with chronic ankle instability, which is in the anterolateral cutter. So if you get patients with such pictures and they have pain in this region, this is nothing but the anterolateral impingement. So take home points, always we do not do an MRI for acute ankle sprain. It is important to look for talar osteochondral lesion and high ankle ligaments in all your patients with ankle sprain because the management changes. So these are the two things that your orthopod is interested in knowing. He doesn't want to know what is the status of low ankle ligaments. Chronic ankle instability, chronic changes of acute ankle sprain plus OA. And in patients with previous ankle sprain and anterolateral pain, closely look at the anterolateral gutter to rule out anterolateral impingement. Thank you.
Thank you, Dr. Chatali, for wonderfully showing the impingement as well as the high sprain and the low sprain. And the important thing to remember when to image. So this is a very important concept, and you have discussed it about it. So thank you very much. Obviously, we don't have a time to take a question, but one more simple question is there Dr. Anil Sharma is asking the one sequence which is must in an acute injury or chronic ankle injury.
If you ask me one sequence,
which sequence is must?
Yeah, I would go for an axial PDFS because that will cover all the ligaments actually. If only thing, you can also pick up deltoid and CFL injuries on an axial PDFS. If you give me two sequences, it's axial PDFS and a coronal PD. These two ones I'll go for.
Thank you, Dr. Chatali.
So
now we'll move to the next speaker, and before we'll move to the next speaker, I'll request all the speakers to stick to their time of 17 minutes, so then we can have some time for the question and answer. Obviously, I know that you are enthusiastic and you want to show more and more of the things. Obviously, there are a lot of things are there in most of the topics, but it's better to keep it in the time so we can finish on time also. So next speaker is Dr. Akansha Agrawal, and she has done a fellowship from the University of British Columbia, Canada. She's presently the consultant MSK radiologist in Jaipur. She did the senior residency from the AIIMS Rishikesh, and she is awarded gold medalist. She's a gold medalist in MBBS and MD, which is quite the very good achievement for anybody. And she's awarded N. Ramdas Best Research Paper Award, and she is a faculty in various conferences. And at her age, she has published more than 30 publications in peer-reviewed journals. So that is a fantastic achievement too. So over to Dr. Akansha Agrawal, and she will be dealing with the anterior medial impingement.
Thank you, sir. I hope I'm audible.
Yeah, you are audible. Please go ahead.
Thank you, sir. I would like to thank the Musculoskeletal Society of India for this wonderful opportunity. I'll be talking about the maladies of the anteromedial ankle and discuss the imaging of anteromedial ankle instability. We'll talk about the anatomy of the medial ankle stabilizer, particularly just the deltoid. Then go on to discuss acute and chronic medial ankle instability, chronic rotatory ankle instability, and then discuss the treatment. The deltoid is the main stabilizer of the medial ankle, and it consists of two fiber bundles, the deep and the superficial. The deep fibers include the anterior and the posterior tibio-talar ligaments. Isolated tears of these deep fibers is very rare, and they together restrain medial talar tilt. The anterior tibiotalar ligament restricts talar plantar flexion, while the posterior tibiotalar ligament restricts talar dorsiflexion. The superficial fiber bundle includes the anteriorly placed tibionavicular ligament, which is actually a thickening of the capsule, the tibiospring ligament, the tibiocalcaneus ligament, and the superficial posterior tibiotalar ligament. These ligaments together stabilize the subtalar and the talonavicular joint. The anteriorly placed tibionavicular and tibiospring restrict talar plantar flexion, while the posteriorly placed tibiocalcaneus and superficial posterior tibiotalar restrict talar dorsiflexion. On this cine image of MRI, we can see the tibionavicular, tibiospring, and the tibiocalcaneus ligaments. This is the superficial posterior tibiotalar ligament. The tibiocalcaneus is the strongest of these ligaments, and it restrains medial talar tilt and external rotation of the talus. External rotation of talus is also limited by the tibiospring ligament. How does an injury to the medial ankle ligaments actually occur? It happens when there is a supination or a pronation force with an external rotation. This can occur when there is direct trauma to the lateral foot, when a person is dancing with one foot on the ground and body rotating in the opposite direction, while running downhill or landing on an uneven ground. So let's discuss acute medial ankle instability. What is the clinical presentation of acute medial ankle instability? The patient will present with medial tenderness, ecchymosis, and swelling. Clinically, there will be tenderness at the anteromedial gutter. There are dynamic clinical exams which include external rotation test and eversion stress test, which are actually quite difficult to perform in the acute setting. In addition to injuries of the deltoid ligament, there can be coexisting injuries like concomitant syndesmotic injury in case of severe external rotation, osteochondral lesions, and injuries to the tibialis posterior tendon. So when we assess by imaging acute medial ankle instability, the first and foremost is the radiograph. Standard radiographs are first used to rule out any underlying fractures if there is an acute trauma. After that, one important thing is to look at weight-bearing mortise view or the gravity stress view to assess the medial clear space. On a weight-bearing radiograph, what we do is we ask the patient to bear weight on the affected foot, and we look for the medial clear space. The medial clear space is the space between the medial border of the talus and the lateral border of the medial malleolus. This space is measured at the midpoint between the articular surfaces. So in this example, we can see that when the patient weight bears, the medial clear space actually reduces and there is a fibular fracture which is quite evident. So when the medial clear space does not get widened, it means that this is a stable fracture. Gravity stress radiograph is a radiograph in which the patient is asked to lie on the couch with the foot overhanging and the lateral surface of the foot points downwards. Gravitational force is exerted on the medial side of the foot. So in this gravity stress radiograph, we can see that as compared to the normal non-weight bearing, non-stress radiograph, the fibular fracture is very well evident on the gravity stress radiograph, and there is clear-cut widening of the medial clear space. Thus, this is an unstable fracture. After that, we come to ultrasound for assessing the acute medial ankle instability. On ultrasound, let's talk about some important bony landmarks which are used to assess these ligaments. Number 1 and number 2, these are the posterior and the anterior colliculi of the medial tibia. 3 is the tubercle of the navicular, 4 is sustentaculum talus of the calcaneus, and the posteromedial tubercle of the talus. So when we join 2 to 3, we can see the tibionavicular ligament. When we join 2 to a point anterior to 4, we can see the tibiospring ligament. Between 1 and 2 and 4 is the tibiocalcaneus ligament, and between 1 and 5 is the superficial posterior tibiotalar ligament. In this example, we can see that the tibiocalcaneus ligament has a fibrillary architecture which is normal for a normal ligament. However, there is minimal fluid around it, which indicates that there is low-grade strain. Deep to the tibiocalcaneus is the deep posterior tibiotalar ligament, which shows ill definition and hypoechoic fluid, suggesting that it is torn. In this example, the tibiocalcaneus ligament is completely disrupted. So is the deep posterior tibiotalar ligament just deep to it. MRI is used to assess the deltoid ligament again, and partial tears are more common than complete tears. However, MRI can also be falsely negative. In addition to assessing the deltoid ligament, it is very useful in assessing coexisting injuries, which include osteochondral lesions, injuries to the posterior tibialis tendon, and spring ligament. So whenever we are assessing a patient with medial ankle instability, it is necessary to evaluate not only the deltoid ligament, but also the flexor retinaculum, the spring ligament, and the tibialis posterior tendon. There is a structure known as the medial malleolar fascial sleeve, which is formed by confluence of the flexor retinaculum, the periosteum of the medial malleolus, and the origin of the superficial fibers of deltoid. In this example, we can see that the medial malleolar fascial sleeve has avulsed off of the underlying bone, and there is a thin sliver of fluid deep to it. Normally, ligaments have a fibrillary architecture and are discrete and taut. In this example, there is a tear of the deep posterior tibiotalar ligaments, which are appearing intermediate in signal and heterogeneous in appearance. In this example, there is complete tear of both the superficial and the deep fibers of the deltoid ligament. On this axial view, we can see that the most anteriorly placed ligament in the superficial bundle, that is the tibionavicular ligament, is avulsed off from the medial malleolus. In this example, we can see that there is hypointense fluid at the site of the medial ankle, which reflects contusion of the deltoid ligament. And in this example, there is a tear of the deep posterior tibiotalar ligament along with an osteochondral lesion. CT scans are used to assess for osteochondral lesions and particularly useful in assessing complex ankle fractures. Chronic medial ankle instability. A patient who has chronic instability will present with a feeling of giving way and may or may not have an acquired flat foot. So clinically, there'll be pain at the anteromedial aspect of the ankle. This is usually associated with injuries to the intermediate fascicles of deltoid. When we ask the patient to weight bear and when there is a loaded foot, the talus moves externally and displaces anteriorly. This results in impingement of soft tissues on the anteromedial aspect of the tibiotalar joint. On arthroscopy, we will be able to see synovitis and probable osteochondral injuries. So a patient will develop osteophytes on the anteromedial tibial plafond, the medial malleolus, and may have an osteochondral lesion in the talus. Clinically, the patient with deltoid insufficiency may present with hindfoot valgus and flattening of the medial arch. When we ask the patient to go on tiptoes in order to activate the tibialis posterior tendon, the hindfoot valgus and the medial arch will get corrected if the tibialis posterior tendon is intact. However, there can be coexisting injuries to the tibialis posterior tendon and even the spring ligament. In such cases, the deformity will persist even when the patient goes on tiptoes. In addition to this, the other signs of tibialis posterior insufficiency will be plantar flexion of the great toe and dorsiflexion of the first metatarsal. This is due to activation of the flexor hallucis longus tendon. Callus can also form on the medioplantar aspect of the great toe. And if the patient has spring ligament tear, there'll be associated midfoot abduction. So coming to imaging for chronic medial ankle instability, first and foremost is the radiograph. Standard radiographs are used to exclude underlying bony abnormalities. Weight-bearing radiographs are again used to assess the medial clear space. But in addition to this, more important are the alignment views. We have to look at the foot and ankle alignment to assess for any valgus change. Detailed discussion of the alignment views is beyond the scope of this talk, but I will talk about the hindfoot alignment view and the talocalcanean angle. In the hindfoot alignment view, we assess for the midpoint of the calcaneal tuberosities, which should lie just lateral to the mid-diaphyseal line of tibia. In this example, we can see that the midpoint of the calcaneal tuberosities lies far lateral to the mid-diaphyseal line of tibia, and thus this calcaneum has a valgus alignment. Talocalcaneal angle is assessed by drawing a line through the mid-axis of the talus and lateral border of the calcaneus. Normally, this angle is between 15 and 30 degrees. When it is more than 30 degrees, there is said to be valgus alignment of the foot. So in this example, there is calcaneus valgus with talar uncoverage. In addition to assessing the alignment, radiographs are also used to assess for bony abnormalities like talocalcaneal coalitions, osteochondral lesions, and periarticular osteophytes. Ultrasound is again used to assess the fibrillary architecture of the deltoid fibers. In chronic cases, when the patient is not in too much pain, we can use eversion of the foot in order to check for any gaping at the site of tears. MRI is again used to assess the status of the deltoid ligament. In addition to that, we can also assess the lateral ankle ligaments because chronic medial ankle instability often presents along with lateral ankle ligament tear. So in this example, we can see that there is scarring of the tibiospring ligament and thickening of the tibionavicular ligament in a patient with chronic deltoid ligament injury. In this example, there is a tear of the deep posterior tibiotalar ligament and secondary arthritic changes at the lateral tibiotalar joint, wherein we can see that there is subchondral bone marrow edema and chondral thinning. Next, we come to the secondary or chronic rotatory ankle instability. Chronic rotatory ankle instability is associated with lateral ligament injury and presents with anteromedial ankle impingement. So when a patient has a tear of the lateral ligament complex, the talus will rotate inwards. And when it does so, it results in an injury or stretch on the anterior fascicles of the superficial fibers of deltoid. So the patient will present with instability of the lateral ankle and pain on the medial ankle. This pain on the medial ankle actually develops with time and does not present at the first visit. So it is very important to assess for intactness of the medial ankle ligaments also when a patient has chronic lateral ankle instability. Whenever there is an injury of the lateral ankle ligaments, there is a distraction force on the lateral ankle and a compressive force on the medial ankle. This compressive force will result in contusion of the soft tissues, the cartilage, and the bone. This can result in synovitis and formation of talar osteophytes. With every dorsiflexion, there will be impingement of the soft tissues at this site. Formation of periarticular talar osteophytes and spurs is best assessed on CT. When there is a chondral injury, initially there is calcification, which over time can go on to form an ossicle. Routine lateral radiographs of the ankle are usually insufficient to assess for these spurs and ossicles, and so there is a special dedicated oblique radiographic view, which is known as the anteromedial impingement view. In this, the patient's foot is rotated externally by 30 degrees and the beam is projected at 45 degrees angulation. So look at this anteromedial impingement view and compare it with the lateral ankle view. In this, we can clearly see the tibial and the talar osteophytes and a small interposed ossicle. This results in anteromedial ankle impingement and pain. So when we are deciding the treatment course for a patient with medial ankle instability, what are the main elements for making this decision? It depends basically on whether the lesion alters the tibiotalar stability. Weight-bearing radiographs and gravity-stressed radiographs, like we discussed, are used to assess the medial clear space, which, if widened, means that there is an unstable lesion. In addition to this, whether or not the patient has had previous medial or lateral instability, the age of the patient and activity level of the patient help in deciding the course of treatment. Acute medial ankle instability is usually treated conservatively with early stabilization, pain control, and use of orthotics. Surgery is indicated if there is ongoing instability, worsening deformities, and limitations in activities. Surgical management includes arthroscopic reconstruction of the ligaments. For anteromedial ankle impingement, arthroscopic debridement is performed. These are my references. Thank you for your attention, and I hope to see you all in Jaipur next year for the annual conference of Musculoskeletal Society of India. Registrations will open next year. Thank you.
Thank you, Dr. Akansha. So wonderful presentations of the intermediate instability. So I think, as you said, that every modality has limitation as well as the usefulness, and we must use like where we can use it, like the radiograph. Like most of the hospital, even the clinicians are usually rely on the radiograph first. Obviously, the different kind of the need to we have shown the anteromedial and the oblique the radiograph, which is quite useful, and particularly we have shown for the gravity, the radiograph with the gravity that can also be useful when the situation is there. So definitely these are the important thing to remember. Dr. Akansha, there is one question here. Dr. Neha is asking that how important is to diagnose injury to each component of the medial ligament complex? Probably she's asking about the superficial component as well as the deep complexes, or particularly the superficial. We have the multiple ligaments. So how important of these the ligament to diagnose these injury, And also, just like there is a dictum for predicting lateral ligament injury, is there something similar to the medial aspect?
Okay, sir. So with regards to importance of identifying each and every component, it is useful to tell that whether the superficial fibers are only involved and whether the deep fibers are also involved, because that would help the orthopod to plan reconstruction. It is not very necessary to describe each and every component of the superficial fiber, like whether the tibionavicular is torn, the tibiocalcaneus is intact, because usually it, like when the superficial fiber is torn, it is a group of fascicles that are torn together. A single fascicle is usually not torn at once. But yes, if you are able to identify, then it is good to mention, but I don't think it will affect management in any way. It is important to tell when there is lateral ligamentous injury. It is important that we look at the medial ankle also and tell if there is an injury, because that can be missed clinically. Because if the patient has not complained of medial ankle pain, the medial ankle ligaments might not be assessed, which we might be able to see on MRI that, oh yes, the medial ankle ligament are also torn in addition to the lateral ankle ligaments. And regarding the dictum for predicting medial ankle medial ligaments, I'm not very sure about.
Okay, so thank you, Dr. Akansha. And we will move to the next
Thank you, sir.
topic. Next speaker is Dr. Uma Maheshwar Reddy, and you can see the long list of achievements. So I will not go into detail, but he's a visiting fellowship in neuro and abdominal, and from the Boston Harvard University. He had done an advanced MSK MRE training, KGS scan Madurai. He's a consultant radiologist and director Clarity Scans, and he's professor in radio diagnosis NMCH Nellore. I think I can see there a lot of the publications, lectures, and the awards to his credit. So as well as he's the editor of the YouTube channel and joint secretary of APIRA. So not going to detail. So over to you, Dr. Uma Maheshwar Reddy, and he will be dealing with the posterior ankle, the region.
Oh, am I audible?
Yeah, you are audible.
Yes, sir.
Please go ahead.
Thank you. Thank you very much, sir. And I give speeches in various forums, but one difference between other forums and this, I can clearly see MSS is more like a family. The people are all together, and I would like to start my lecture by reminding our beloved Kakarla sir. Thank you, Maya sir, for that wonderful introduction. Next time I'll keep it very short so that it will be useful for you. And Jairaj sir, thank you. You've always been inspiration, and special mention about DK Singh sir for motivating me up to taking this challenging lecture. And he said you can do it, and he just helped me, motivating me. And Ramakrishna, oh, I can see your hard work. Always thanks for being such a buddy for me. Okay, let me go straight away into my topic, which is panorama of posterior ankle pain and posterior ankle impingement and Achilles imaging. So, posterior ankle pain is caused by painful limitation of plantar flexion. Let me just automatic. Yeah. Sorry, just reshare it. Yeah. So let me straight away go into relevant anatomy. What is important is posterior process of lateral tubercle is one of the most important thing. Lateral tubercle of the talus is one of the most important thing which you should be knowing. And these are the ligaments which are most important, relevant to understand the posterior ankle pain. This is posterior inferior talofibrillar ligament, which is here. Then inferior transverse ligament, inconsistent ligament, we may not always see this ligament. Then this one important ligament is very important to understand the posterior ankle impingement, and we have to understand the posterior talofibrillar ligament and calcaneal fibrillar ligament. And again, this is in relation to the most important tendon, which I would like to emphasize here is the FHL tendon. You should know about the FHL tendon here, which is important to understand posterior ankle impingement. This is the anatomical specimen. So most important thing is we see mostly when there is an acute plantar flexion, you see this posterior ankle pain, and here there will be impingement of some loose body or some problematic osteogonum or anything will cause pain in the posterior ankle region. So what are most important things? When there is aggravating factors like repetitive plantar flexion, you have to definitely think about a PACE, which is called acute PACE, which is commonly seen. What they say in this article is whenever there are significant findings and it is unlikely that patients will not have pain. And again, most of the other causes, like for example, patient having medial pain or anterior pain will have some related features in the posterior ankle also. You should be very careful while interpreting them. Only when there is a proper clinical history, we should start interpreting them and calling it as acute posterior ankle impingement. The most common case in the illustration, this is the osteogonum syndrome, which is one of the most common. Then we see the STIDA process, and we can see the downsloping posterior tibia, and a fractured osteophyte sometimes can cause, and a Haglund deformity, and also some soft tissue thickenings. All these things are the commonest causes of posterior ankle pain. And these are the features. One important feature I would like to highlight is look at the fluid around the FHL and also thickening of the intermalleolar ligament. You can see the marrow edema of osteogonum, posterior talus, and posterior tibia. You can see the synovitis in the posterior to the tibiotalar joint, and we can see tenosynovitis of flexor hallucis longus. So these are the findings which you can see. This is a more obvious borrowed image. We can see this osteogonum here, which is seen very well on X-ray, and you can see the inflammation happening in the posterior, inflammation happening posterior. Here, this is the graphic image. Let me straight away go into some of our known cases. Here in X-ray, you can see well corticated, which we should, cortication is one thing which will help us differentiate from other fracture or a STIDA process. You should definitely look for cortication. So to understand what is important is, this is type 1 osteogonum. These are the types of osteogonum which will be seen separately. There won't be any communication both from the talus and the osteogonum. Here there will be a cartilaginous layer and there will be a communication. Here in this is elongated STIDA process. How is it differentiated? In sagittal plane, it will extend beyond the lower tibia. So that is how. So basically, this same spectrum, osteogonum and STIDA are same spectrum. And these are very close differential diagnosis, but we should make an effort to differentiate both. Treatment may not vary much. And this is a asymptomatic patient, came for some other ankle pain. So sometimes these are findings which you can see asymptomatically, and there is some amount of fluid here that is also normal. So some amount of fluid in the retrocalcaneal space and some amount of fluid in this joint space can be normal. This patient didn't have any of the posterior ankle impingement findings. This patient came for the evaluation of ABC of talus. And you can see again, there is an elongated osteogonum, which is again, you can see the synchondrosis here. So this is again an incidental finding. So this case was very important. And this child was a 19-year-old Bharatanatyam dancer. You can appreciate there is a clear osteogonum here. And there is a synchondrosis. This is a type 2 type 2 osteogonum. And when we can see the edema, which is one important sign. The edema is one important sign we should be able to appreciate. And there is amount of fluid in the FHL and also in the recess, which is posterior to the ankle, which are very important. You can also appreciate thickening of the PTFL. So that is one important sign, which we can definitely try to identify the posterior ankle impingement syndrome. So this is a classical case of osteogonum syndrome. So next case again, it's a relatively more severe, more fluid, more inflammation happening here, and the edema is also extending into talus posteriorly. You can also see some amount of inflammation happening in the sinus tarsi region and thickening of the talocalcaneal ligament. So here again, very large osteogonum, which is causing profound osteoarthritis, subtalar osteoarthritis, edema in the calcaneum, subchondral cyst, and inflammation is happening here. So these are the very large osteogonum is important. Such things are mostly candidates for arthroscopic resection. Smaller osteogonums can be treated initially with steroid. So that is how you can definitely diagnose them. Indirect signs are one important thing I would like to highlight is the cutoff of the FHL tenosynovitis just at the level of ankle osteogonum is one important finding which I would like to highlight. So beyond normal inflammatory arthritis, the tenosynovitis will extend beyond. But however, if there is a FHL osteoarthritis cutting off at the level of osteogonum, you should always think about some problematic osteogonum. So again, this is a thickened intermalleolar ligament. Always in posterior ankle impingements, you should put an effort to find intermalleolar ligament, which is a relatively difficult structure to visualize. But definitely, if you see that, and if you see some inflammation in the posterior ankle, you should definitely diagnose this. And this is a borrowed image where you can see the thickening of the posterior talofibular ligament. And you can, this is again one important finding in cases of posterior ankle ligament. So finally, summarizing osteogonum syndrome, fluid in the synchondrosis, FHL edema, scar indicated of posterior ligament injury, and synovitis. These are the findings. So coming to the second important entity called elongated STADA process. So this is a radiograph, very good in finding STADA process. This is our case where you can see that elongated STADA process is seen. There is inflammation in the Kager fat pad. And here you can see there is again some amount of subtalar arthritis in the hind foot, and soft tissue thickening just inferior to the fibula. So these are the findings in STADA process. Again, I said the thickening in FHL fluid, thickening of PTFL, and also some degree of minor degree of thickening of intermalleolar ligament. These are the findings. So this is a elongated STADA process. This again a case where this was the patient had both anterior impingement and posterior impingement. Here you can see the classical tibial osteophyte, which is crossing beyond the tibial plafond. And if you see the STADA process, these are the multiple fractures. This guy was a cricketer, and he was playing for a district level, and he had this problem, and definitely an arthroscopy was suggested for him. And here there was an acute plantar fraction, and followed that there is a fractured STADA process, and there is fluid here, and there is inflammation in the Kager's fat pad, and these are the findings of acute plantar fraction causing fractured STADA. And the borrowed image of Shepherd's fracture, you can see this is again elongated or a normal lateral process with a fracture. You can see, and again findings like loose bodies should be carefully looked at. A young patient, generally you don't expect a loose body, but this patient had a loose body and posterior ankle pain, distension of the posterior talar capsule. So this tibiotalar capsule, and this is how you can find. And these are not very uncommon findings. Sometimes you can see the ganglion cyst along the intermalleolar or PTFL, again our own case where you could see classical ganglion cysts, which are result of a chronic repetitive microtrauma and ligamentous thickening. So just to conclude posterior part, one or two slides about posterior medial impingement. It's nothing but the thickening of the posterior fibers of the deltoid and posterior capsule resulting due to a chronic inversion injury. And you can see all these findings, and you always appreciate the osteochondral defects. And this is thickening of deltoid and edema in the talus, and edema in the medial malleolus. This is how this is a borrowed image of posterior medial ankle impingement. So yeah, these are the repetition of the findings. Due to lack of the time, I'll just move on to my next lecture called next half of the topic. So in summary, posterior ankle and posterior medial ankle impingement, you have to look for loose bodies, you have to look for osteogonum, you have to look for all the other findings, and you have to see the subtle findings like thickening of intermalleolar ligament, PTFL, and you have to diagnose posterior ankle impingement. And coming to Achilles imaging, and this is a very commonly used dictum. This guy is good at everything, but he has Achilles heel in certain subject or something like that is used. So this is again when Mother Thetis dipping into the sea of where there we can see that Achilles, she held at the Achilles heel, and there was the part was not dipped, and she had caused damage to the patient, the person. So okay, just randomly a question popped up, so it disturbed me. Sorry. And this is how the Achilles tendon is formed. You know, both the aponeuris of gastrocnemius and soleus forms this Achilles tendon, and you see the length of the Achilles tendon is around 10 to 15. What is more important is there is something called watershed area at around 2 to 6 centimeters from the attachment. Here you can see this is the approximately this 2 to 6 centimeters area is very least vascular, and ultrasound is one of the best modality to diagnose Achilles tendon tears, and MR is just an addition. And most of the times it is, you can see, we should always be wary about the magic angle artifact. So this is the Achilles tendon, this is the Kager's fat pad, all these things, this is a normal tendon. It depends upon resolution of image what used. And this here in this axial image, what I would like to tell is the soleus comes from lateral to medial as you go down. You know, the bump of the soleus, you can see that it is coming from the lateral to medial here. So this one thing is important. Okay. So these are the normal Achilles tendon. Normally, you don't see any concavity. It is straight and it should be somewhere between 6 mm thickening. So, and less than 6 mm is normal. Sometimes if you see a convex bulge and it is thickened, we should definitely think about tendinosis. Both you should use that sagittal image, non-PDFS and PD images to evaluate the Achilles tendon. Always assess at the insertional sites. So this was the vascular anatomy which I would like to. This is where the perineal artery supplies, and here you can. This area where is a watershed zone, especially mostly in the medial aspect. It is least vascular, and there is also supply from the posterior tibial artery. This was earlier they used to think this is the water supply, but now it is changed. The concept is they are thinking that this is the reason. This is a borrowed image where we could see this is a low-lying soleus. Sometimes and attachments will be like you can see a split-like low-lying soleus, and you can see fluid signal intensity. It should not be confused with any tear, and that is one important aspect I would like to emphasize. Then this exam spotter and most important finding borrowed image where you could see the accessory soleus muscle, and we can definitely identify it just anterior to the Achilles tendon. You should not only when patient is having exertion, sometimes he can present with pain. So it's again a case of posterior ankle pain. You should always be knowing this condition of accessory soleus. So let me come to some of our own images, and always this plantaris tendon will be lying next to the Achilles tendon. You should it is the longest tendon. Like thickest and strongest is Achilles and longest is plantaris tendon. You see this, and this sometimes is used for augmentation. When there is a tear greater than 3 centimeters, you can definitely use plantaris tendon or tensor fascial latae to augment the Achilles tendon. So you should be knowing this plantar tendon, should not be. So coming to tendon degeneration and tears, you should definitely mention in your report whether it's insertional or non-insertional. And what these are the things which you do, whether it's insertional, non-insertional, size of the tendon, size of the gap, and whether it opposing tendon fragments, how are they, are ragged or smooth, and is there any associated Haglund deformity? Is there associated any xanthomas or familial cholesteremia? You should be able to tell. So this is a calcaneal osteophytosis or enthesophyte. You can see in X-ray, you can definitely diagnose it very well. In CT can also help sometimes to see the enthesophytes very well. This is a beautiful Achilles tendon, but most of the important work is done in USG, and so panoramic borrowed view. And this is a Achilles tendon from the attachment of onto the calcaneum to the entire length, and the Geiger's pad inferiorly. So this patient had both insertional tendinosis and non-insertional tendinosis. This is non-insertional tendinosis and tendinosis that the attachment. Patient also had small enthesophyte, and they definitely you can see this normal cavity is lost and it is bulged. So this is again in sagittal how we appreciate the non-insertional tendon thickening. Okay, and here again, this is a case of insertional tendinopathy with partial tear. Just to create an impression of what are important, and this one case I would like to spend some time on. So this is again a classical case of Haglund syndrome. There is enlargement here and tubercle, and here you can see the fluid in the retrocalcaneal bursa. There is tendinosis, and there is a clear tear of the Achilles tendon. So this is a classical case of retrocalcaneal bursitis and enlargement of the posterior superior aspect of the calcaneum, and here there is inflammation in the Chagas fat pad. In this case came for some other problem. Incidentally, we picked up this, but just to say that like sometimes neglected when the pain is more on some other, this patient, this was a proven case of lymphoma, contrast image, and you can pick up a tear like this insertion. This patient was not really bothered by the tear. So this is recent case where there was a Sever's disease where patient had trauma and there was almost loss of calcaneal epiphysetis. And here you can see that hematoma here, and the patient also had some interstitial tear of the Achilles tendon. You can definitely appreciate interstitial tendon. Another Sever's disease progressed to the calcaneal osteomyelitis. There was inflammation here clearly, and this is the at the level of insertion there was tendinosis. So Sever's disease with osteomyelitis and Achilles tendinosis. This is one interesting case I would like to really show. The patient had insertional tendinosis. This patient had 2 level tears. This level tear and this level tear. 2 level tears were there in this patient. An ultrasound was depicting it very beautifully. So starting from above superiorly, you can see the tear which is above partial tear. And this was more obvious and more dangerous tear. I know at such patients it becomes difficult to treat again. So you can appreciate the entire length on a video we have tracked up, and the insertion also was showing some amount of tendinosis. Okay, so this is again retracted tendon thickness, and here there is definite retraction. Such patients may require, when the tendon retraction is greater than 3 centimeters, they may need some augmentation. So our own case, again, there is a clear defect. And tear, we can non-insertional tear, you see. This is insertional tear. So I'll skip these things. This is again a repetition. So what I'll tell is, this is one important: partial tear, non-operative, complete end-to-end anastomosis when the defect is less than 3 centimeters. So defect size is one important thing. And so you may, when it is very large defect, you may to have synthetic graft or larger graft. So the paratendonitis, a borrowed image. This is one thing. Achilles tendon does not have any synovium, or we don't call it as tenosynovitis. You call it as paratendonitis. Why? Because it receives all the blood supply from the paratenon, and this is the inflammation which is seen here. This is the inflammation seen here. So paratendonitis is a common thing. And you can definitely diagnose inflammatory arthritis in a case of retroachilles tendinitis was the bursa was there in this case, and this was a case of inflammatory arthritis. So I'll just we'll skip some slides and we'll talk about again one more retroachilles bursa. And this is a classical Hagelin syndrome. Again, there was increased vascularity and there was clear enlargement of the tendon here, and there is fluid in the retrocalcaneal bursa. So there was a dilemma whether it's an inflammatory arthritis or Hagelin syndrome. Abscess sometimes will contribute to Achilles tendinosis, calcaneal osteomyelitis with fluid in the Keges fat pad. And this is a tendoachilles abscess. So neglected chronic tears can cause tendoachilles abscesses. And last few slides, this is a classical case of Ritter's syndrome, where there was inflammation in the posterior ankle and there was definite tendinosis also. This patient had again inflammation here also. So this is a post-contrast image showing classical inflammation in a case of Ritter's syndrome. And last pathology, which I would like to emphasize, is this tendon xanthomas. There will be T1 homogeneous increased signal intensity because of deposition of beta cholestanol, and you can also see findings in the brain. This is a classical case of cerebrotendinous xanthomatosis, and a recent case where the patient had premature cataracts. There was they had a pseudophakia, so hugely enlarged Achilles tendon. So this is very important pathology to know. You should not label it as some tendinosis or tendon tear. So thank you very much. Hope my lecture on both posterior ankle impingement, it was very, very vast. I had to go a little fast. Blaze. Thank you.
Yeah. Thank you, Dr. Uma, for showing the Achilles tendon as well as the posterior impingement. Thank you very much. The very interesting case you have shown about the Achilles as well as the posterior impingement. Obviously, we have one question, but before that, I can ask you one question, because that is important in day-to-day clinical practice. Many times we see, Dr. Uma, that there is some the enlargement of the calcaneal tubercle, but we don't see the other component of the Hagelin. And so, what do you see? A patient patient is symptomatic. What do you say about it? You just mention the finding and then just leave it, or you say that what your approach?
Sir, tubercular enlargement can be mentioned and leave alone only when there is associated retrocalcaneal bursitis, when there is tendinosis, All the things are there, then only we should call it as Haglund syndrome, sir. That is what I believe.
Okay, thank you. Obviously, so we don't have a time for more question. Probably we'll take some more question in the end, as the organizer has told me that we are running late. So we
Sure.
are not taking more questions here, and we'll take if we have a time, we can skip some of the time for the break also to just cover up. So we'll move to the next lecture, and the next speaker is Dr. Ankita Ahuja. She's a consultant MSK radiologist in Innovation Imaging and NM Medical Mumbai. She's assistant professor Tata Memorial Hospital Mumbai. She done the fellowship in MSK and intervention and founder member of Cafe Ranjan, associate editor of IJMSR, which is very, very important for the growth of our the society and the journal. And she's a faculty of state, national radiology and orthopedic conferences. And she has a publication, national international journal. So thank you, Dr. Ankita, and over to you for your presentation.
Thank you so much, sir. Thank you, MSS, for the invitation. Thank you, Jairaj sir, DK Singh sir, Mahesh sir, and everybody for the opportunity. It's a pleasure to be a part of MSS, and I think the most best feeling you can have as a member. So I'll not take more time. I'll just start my presentation. So what we are going to discuss today is imaging of the extensor compartment and extensor retinaculum. As most of you would know that this is, I think, the most ignored area. We don't give it that much importance. I agree with you, the abnormalities in this region would be less common than the other compartments, but we need to look at this because it's not that rare as well. So what we are going to do in next 10 to 15 minutes is just do a recap of the anatomy and look at the common pathologies. So anatomy has been beautifully covered in the beginning, but just to cover up again, that there are in the anterior compartment, we have three tendons, your tibialis anterior, extensor hallucis longus, and extensor digitorum longus, along with the neurovascular bundle. And then you have the two retinaculums which are holding, like you have the peroneal and the flexor retinaculum. Similarly, over here, you have the extensor retinaculum, which is a superior extensor retinaculum and an inferior extensor retinaculum. So let's go and have a look at the anatomy. So here is your actual MRI weighted image. You can see tibialis anterior, a smaller extensor hallucis longus, and a broader extensor digitorum longus, along with the neurovascular bundle running over here. We'll just go through this. And as you see, there is a thin band which is covering here at the level of distal tibia. So this thin band, which you can see at this level, this is your superior extensor retinaculum. As you go down towards the level of almost the distal most tibia or the upper talus, as you reach, you see another band which is going deep to the tibialis anterior tendon, and a very thin band which is covering the top. So this is your inferior extensor retinaculum at this level, which splits into two bands. This is called as oblique superior medial band, the deeper component of which is thicker, and it encases the tibialis anterior tendon. Now you would be wondering why I'm telling you so much about these two bands. So why we are talking about this? Because this is the area where the tendon becomes a little avascular, tibialis anterior tendon, and there are more chances of injury, which I'm going to show you later. So at this level, you see your inferior extensor retinaculum, which splits and encases the tibialis anterior tendon. Then as you keep on moving forward, you can see all the structures again from tibialis anterior, extensor hallucis longus, extensor digitorum longus, and your neurovascular bundle. And you keep on tracing them till you can reach up to the insertion, right? So whatever is covered, you try to reach up to the insertion. So you can see over here, your tibialis anterior is inserting on the medial cuneiform or the base of first metacarpal, and your extensor hallucis longus goes up to the insertion till the distal phalanx. And similarly, your extensor digitorum longus also goes along the four toes up to the distal phalanges. One more important thing, just don't see any structure in one plane. I think if you ask a question, which plane is better, that's a wrong question. You can obviously see one thing better on one plane, but you need to analyze it on all the planes. So try and look for all your structures on all the planes, and that is very important because sometimes you may get a better clue on the other plane. Dr. Harsh has shown very beautifully the ultrasound images. Similarly, on ultrasound, you can pick your tendons well along with the neurovascular structures as well. And when you portray a longitudinal image, you can see the tendons well. The importance is that anterior compartment is very superficial, so you can analyze the anterior structures pretty well on the ultrasound as well, right? Now moving on to the pathology. So what we need to know is that most commonly anterior compartment is affected because of the systemic inflammatory infective etiology. But your trauma, degeneration, and especially ankle impingement can affect the anterior compartment structures. What it will affect, you all know what we discussed the structures are, that is either the tendon or retinaculum or the neurovascular structures. So let's discuss trauma and degeneration together, and then we'll just touch upon the impingement. So tendons are the ones which are most commonly affected when we talk about the trauma and degeneration. The most important thing which you should remember from these 10-15 minutes of talk is your anterior extensor tendons have a synovial sheath, but there is no fluid at all in the sheath. Like if we have listened to the previous talks, flexor hallucis longus might have a minimal fluid because it has a communication with the joint, but there is nothing like that in extensor tendons. So you have no fluid along the extensor tendon sheaths. If you see any fluid within the tendon sheath, then that's a tenosynovitis or a synovitis, and you need to report that as an abnormal finding, right? And as I mentioned before, trace all the tendons on all the planes because you may get some of the other information because they all have an oblique course. Now, as you all know, if either trauma or degeneration, this is the path which you usually see amongst the tendons, how they're affected. Either it can be a tenosynovitis or a tendinosis or a tear. So let's just see the images and the spectrum. Ideally, this is a case of inflammatory tenosynovitis, and you can see all the compartments are affected, and as such, our anterior compartment is also affected. So this is a case which is showing tenosynovitis of all the extensor compartment tendons. Then moving on to the next case here, I'm so sorry, just give me a second. Yeah, so this is your tibialis anterior tendon on your sagittal images. Can you see over here till here the tendon is normal and then the tendon becomes too thick. As I keep on tracing the tendon is very thickened and very hyperintense signal with multiple bright areas within. It's same over here. And as it's approaching towards the first metatarsal base, it again becomes normal. So let's just quickly have a look at this video. Keep an eye on tibialis anterior over here. See how thickened and degenerated it is. And it is again becoming normal as it reaches towards its insertion. So this is a case of advanced tendinosis of the tibialis anterior tendon. This is another case. This is extensor digitorum longus tendon, and you can see how advanced tendinosis is. Although this is a case of post-trauma, this is a kind of a remodeling tendon injury, which is pretty tendinotic right now. Then the next step in the trauma degeneration spectrum would be tear, which would be much more common with the trauma cases. So there can be a direct trauma and it can lead to tendon tears, and you can see the tendon stumps which you are seeing over here on these images. But obviously your through and through images will show you better. So let's keep an eye on tibialis anterior. I'm sorry, the video is running fast. So let's keep an eye on the tibialis anterior and extensor hallucis longus tendon, which you can see with the red arrows. And you keep on tracing them, the tendon goes off. Tendon goes off. We don't see any tendon remaining over here. And as we move forward, we start to see some little bit of tendon which are coming back over here, right? So this is a case of full thickness tendon tear, which was because of trauma. And if you remember this slide, you can see a lot of other impacts of trauma. You can see a tendo-Achilles tear as well. You see a lot of soft tissue edema, a lot of subcutaneous edema all over, which are another clues that this is a traumatic case with full thickness tear of the tendons. So in this case, we have a tendo-Achilles as well as an extensor hallucis longus tear. Whenever you see a tear, what all you need to report is you need to talk about how big is the tear. So how will you do that? You have to figure out where is the proximal and distal tendon stumps are. If it is only an ankle study and you feel the tear is going further, you need to cover it up, or you need to do an ultrasonography and figure it out, right? But you need to figure out where the stumps are and how good is the quality of stump, because this case might be surgical. The other cases, they might just treat conservatively, but this case would be surgical because it might be, if this is an athlete, it might be affecting the management, or if it's a young patient, it might be affecting the day-to-day life of the patient. So this would be surgical. So you need to mention all these features. Now, we have talked about this, and as I was talking to you, why was I trying to show you inferior extensor retinaculum? Because when the tendon passes deep to it, it has a little avascular zone, and that is the most common site, which is approximately 0.5 to 3 centimeter proximal to the insertion, and this is the site where the most common injuries or tears happen, when it is most likely because of degeneration, because trauma can happen everywhere. This is just a case to show you that the tears can happen in the later course also, not only in the ankle, as I was trying to tell you. So you need to see the tendon in entirety, right? So just keep an eye on extensor hallucis longus tendon over here. So if you see, you can see the tendon over here, and then the tendon goes off. You do not see any tendon. And then the tendon is, sheath is seen, and here the tendon is coming up back again. So if there is a trauma case, trace the tendons in entirety, just not focus on a specific area. The injury can be distal, as we saw in the previous case, or the injury can be proximal, as we are seeing over here. This is a myotendinous junction injury of the extensor hallucis longus tendon, right? So see the entire course. In last 2 minutes, I'll be just touching upon the anterior impingement. But before going that, what do you mean by impingement? If there is any soft tissue or any extra bone which is hurting the structures in the surrounding and causing symptoms, that is, in the most simple words, impingement. In anterior compartment, what all it can hurt? We all know it can hurt the neurovascular bundle, it can hurt the tendons, or if there are both sides bones, then they can hurt each other and cause a bony block. So how will the patient present? Either with a limited range of movement, or there might be pain because of neurovascular or extensor tendon involvement, right? So you all know about this. What are the types of impingement? Anteriorly, there are 3 impingements: anteromedial, anterior, and anterolateral, out of which medial and lateral have already been covered. So I want to show you just 1 or 2 cases of anterior impingement. So commonly, anterior impingement is a sequel to chronic ankle sprain, which has been lingering on, not dealt well with. So body forms osseous prominences over here. When these osseous prominences are there, you can appreciate them very beautifully on X-ray, and people diagnose them on X-ray. MRI is usually done to look on the chronic ankle sprain part, how the ligaments are looking, what all other problems are there. But on the same time, on MRI, you can still identify the osseous prominences, and in this case the patient presented with a bony block on dorsiflexion. As you can see, when this will impact against this, there will be a bony block. Similarly, you can have bony blocks which are irritating the tendons as well. So in this case, this is a lateral bony block which is irritating the extensor digitorum longus tendon, and as I told you, there should not be any fluid. If you see any fluid, it is abnormal. So this bar is irritating this tendon over here. Similarly, this is again another one which is a little lateral and in close proximity to the neurovascular bundle, right? This osseous prominence. So this patient presented with the tingling sensation on dorsiflexion, and this was the reason, and this patient was operated and did well. And similarly, like shown previously, some soft tissues can also cause the anterior impingements. So to summarize on, hopefully on time, first of all, most important thing, don't forget to look at the anterior compartment, the tendons, neurovascular structures, and the retinaculum. Retinaculum would be injured along with the tendons. The most important point which I want you all to remember from the end is tendons have no fluid. Anterior compartment tendons have no fluid along the tendon sheath. And if you see any fluid, it's abnormal. Always look at the tendons in entirety. Injury, degeneration, anything may happen anywhere. So you need to trace them entirely. And if you have cases with bony block or anterior pain, try to figure out if it is because of anterior impingement. Thank you so much.
Thank you, Dr. Ankita, and you are well ahead of time. So thank you very much for saving the time for the question and answer. So I have one question regarding your presentation.
Yes, sir.
Like many times we see the osteophyte in the talus also, and not in the tibia.
Right.
And
sir.
many, even some of the the other cases, you can see this finding. So do you think you mention it's a kind of like the impingement, or you just mention it just
So, sir,
like
I usually mention it. This could be concerning for anterior impingement, and clinical correlation for signs and symptoms is requested.
okay. So until we see some synovitis or some other changes adjacent to
So, sir,
it,
if
you will.
we see all the changes of chronic ankle sprain and these osteophytes, I usually mention them and then I leave it for the clinician to take a call. But if I see synovitis along, then I say this is concerning for anterior impingement.
Good, good. So, okay. Thank you, Dr. Ankita. So we have a 2 minutes. Still, we are at 2 minutes, so we can take some questions. Dr. Uma, are you there? Dr. Uma Mahesh, are you there? Okay. If it's not there, then we'll move ahead. And then the next, the speaker is the Dr. Srajita.
Yes.
Are you there? Okay.
Yes, I'm there.
Thank you. Okay, okay.
Sir,
So
Mahesh sir, they have just unmuted me.
okay, sure. Okay, okay.
So there was
we'll
a
take it
question
last.
I've seen in the chat box, sir, and
Okay,
they were
sure,
asking
sure.
about
Yeah,
FHL
please. So,
tendon.
yeah, please go ahead. Have you
Yes,
read
sir.
about
Yeah,
the
yeah,
questions?
as
Please.
I just want to answer that FHL tendon, when the fluid is just getting abruptly cut off, just at the level of any loose body or osteogonum or a stida process, you should definitely, one sign which is described, you have to think about posterior ankle impingement. That is one thing I would like to answer, sir.
Okay.
Please, Srijita madam, please. Thank you. Thank you.
Yes.
Dr. Srija, you can you do the full screen?
Just a minute. Is it full screen?
Not. Just check it. Yeah.
Madam,
What to do? Yeah, now is it full screen?
ma'am, I think you need to download it.
No, it's already downloaded on my laptop.
No, ma'am, you're presenting it from the Google,
No,
Google slideshow.
wait, I'll just reshare. Just a minute. Now?
Yes.
Yes.
Yeah.
Thank you. Yeah.
Okay.
So, yeah. Thank you, Dr. Srita. So, Dr. Srita is a senior consultant radiologist at Apollo Multi Hospital Specialty Hospital, Kolkata, and she has contributed 2 chapters in IRA textbook, which is available now. She has an interest in resident teaching, and she has awards in IRA, like IRA President Appreciation Award. So, over to you, Dr. Srita, for your presentation.
Okay. Thank you so much. At the outset, let me thank you, MSS, Dr. DK, for this opportunity. I'll come back to that later at the end of the talk. So my session today, am I clearly audible?
Yeah.
My session today is on a specific 2 areas of the ankle, which are relatively less discussed and appear a little dark. So let me see at the end of my discussion whether I can throw a little light at the end of the tunnel. Okay. So my imaging of our tarsal tunnel and sinus tarsi, these are the 2 regions I'll be talking about. And instead of a conventional turn of going through the anatomy, the modalities and everything, I have chosen a different method by 2 real-life cases to make you understand the importance why we are spending 17 minutes on these 2 areas of the ankle. So let's start with the case number 1. This patient, a 35-year-old man, has come with a bad twisting injury of the ankle 5 months back. Suffering from this chronic ankle pain, it is not going away totally. Has been treated conservatively, visited 3 doctors in the chain. In the process, has undergone a plain radiograph, a CT, MRI, nothing yet working for him. Finally, the MR has been reported that there is some fluid in the lateral aspect. So now the radiologist has been asked for that, please do an USG guided ankle joint aspiration, send it for some tests and find out what the pain, because the patient is not really getting out of this morbidity. So the radiologist, instead of just performing the ultrasound guided aspiration, first retakes the history of this patient, re-examines the patient and gets all the reports that were done previously. The radiologist saw that the AP lateral reported X-ray were normal, CT was reported normal, and MR was reported as edema in the region of the calcaneofibular ligament. That is the cause of the sprain, the point, and some amount of joint effusion. Relook reveals what? First, the patient complained that, yes, I do have a pain, which is more on severe, now that the acute pain has gone. But what is debilitating is the pain is there when there is an acute inversion or acute eversion, specifically when I am walking on an uneven ground. Remember, just noted the patient had bad pain in somewhere in the deep pain when there was walking on an uneven ground. We made the patient lie on the table. Instead of putting our probe directly, we examined the patient. This U-shaped thing is the lateral malleolus, and the finger right now is pointing where an ATFL tenderness would have been. The patient was pressed there. Yes, there was pain. But one finger below that, when we pressed, the patient just winced in pain. So this is the lateral malleolus. Over here is the expected ATFL. Just one finger below that, the patient just winced in pain. Now, what did the radiologist do? Took out the radiograph of the MRI. Yes, the MRI did show significant edema here under the peroneus brevis in the region of the CFL, as well as, and also a little amount of edema was there in the deltoid. Someone is writing something over here. No, that's okay. I'm audible and I can be heard, right? And the pictures can be seen.
Yeah, Dr. Sejta, you are audible and we can see
Okay,
clearly.
fine.
Please
So
go ahead.
yes, there was definite edema in the CFL, a little bit of edema also in the deltoid. But what else was seen? There was an edema in the subtalar region, the talus, calcaneum. Look at this PD fats, non-fat set image, how the fat can't be seen. It's all hypointense over here. What is ideally to be seen? This I've kept to show you what ideally this area should have a lot of fat, and there should be some ligamentous structures like this, and it should not be looking like this. So now what did we do? Instead of doing the with aspiration, we just injected some local, can you see the video? We just injected local anesthetic over there and waited for some time and told the patient to walk. And what did the patient say? Oh my God, I have never experienced such relief. That pain which I'm suffering from has amazingly just disappeared. So what did the radiologist make? Made a diagnosis of what is called a sinus tarsi syndrome. Now going to the details of the area. What is this area? This is the area of the sinus tarsi, which is between the anterior, it is bounded, the bony boundaries is the neck of the talus, and here is the calcaneum. So this zone is what we are going to discuss about. Now what to understand that there is something called a subtalar joint. A subtalar joint is the joint between the talus. Calcaneum has three facets: posterior, anterior, medial. Medial is not that important. Anterior and posterior are important. And this area separating the anterior and the posterior subtalar joint is the sinus tarsi, which contains blood vessels, a number of ligaments. Actually, in theory, you will find that there are a number of ligaments, that is the extensor retinaculum, lateral cervical, something called a bifurcate ligament, and the medial talocalcaneal interosseous ligament. But practically, you have to see these: cervical ligament and the talocalcaneal ligament. Why do we have to know about these ligaments? Subtalar joint stability is by few set of extrinsic and intrinsic ligaments. While the extrinsic ligaments, which usually catch our eye in ankle sprain, is deltoid over here and the CFL over here. Remember, deltoid and the CFL are the extrinsic stabilizers of the subtalar joint, while it is also stabilized by the intrinsic ligaments, which are the sinus tarsi ligaments. Out of the four ligaments, we actually have to concentrate on the lateral cervical ligament and the interosseous medial ligament. Let's see how these structures look. Since they are soft tissue structures, will be dealt in the MR part. Yes, sinus tarsi is best imaged by MR. Wow, how does this area look? How do we expose this area totally in a radiograph by an oblique X-ray of the ankle like this? Look at these small calcific densities over here. They are not supposed to be present here. If they are present, means there is either a chronic calcification of the ligaments there or an avulsion injury of the ligaments there. And there is another view called the sinus tarsi view, which is an oblique lateral view. If it's a normal lateral view, this tunnel will not be exposed like this. If an obliquity is there, then we can see this area carefully. So basically the bony area, subtalar joints, sinus tarsi, bony boundaries are well seen on radiograph. Role of ultrasound. No doctor will tell us to diagnose sinus tarsi syndrome without just doing a diagnostic imaging. Main role of ultrasound is to prove sinus tarsi syndrome as we do it by injection of lignocaine. And otherwise, another thing is, since this area mimics peroneal tendinosis, laterally, we also see these tendons well on ultrasound and to find out whether what is the cause of pain. Is it peroneal tendinosis or not? From that, when we actually image a known case of synovitis over there, we can see sinus tarsi fat, distant subtalar recess, synovitis with erosions like over here. And so the main role that is there for ultrasound is diagnosis of sinus tarsi syndrome by injection of lignocaine, as well as to see mimickers like peroneal tendinosis. Role of CTs. Now, CT is mainly for bony structures. We see CT to look for any associated coalition like this. And of course, subtalar arthritis, which is clearly seen here. See both posterior and the anterior aspect. The joint space is reduced over here, the subtalar joint. And this is also, this area is compromised. Role of MRI, which is very important. First, again, I said, why are we studying these? Because it's an intrinsic stabilizer of the subtalar joint. What are the extrinsic stabilizers? The deltoid and the CFL. This is how they look like. MRI are the extrinsic stabilizers of the subtalar joint. Intrinsic stabilizer are this. Since this is the medial aspect, medial malleolus, this is the interosseous calcaneal ligament. As we go laterally, I have not scrolled through images. There are no videos. As we scroll laterally, a beautifully performed MRI will show the cervical ligament clearly. This is the lateral malleolus. So this is the cervical ligament coming. This is how the area looks. As Ankita said, everything has to be seen completely in all imaging sequences in all planes. So this is how the thing looks like in coronal imaging, and this is an axial imaging. Let's come to the pathologies. This is the case that I've already discussed. This patient had an ankle injury of the primary extrinsic ligaments along with the interosseous ligaments. So these ligaments are strong ligaments. They are secondarily affected after the deltoid and calcaneofibular ligament isolated. They're usually not sprained. But when sprained, when we see an ankle sprain and we see a deltoid ligament and a calcaneofibular ligament sprain, please go through this area also to look for even the most subtle abnormalities which need to be reported to prevent undetected chronic pain. What are the other things? Subtalar arthritis, like here, totally the joint, that space is totally gone. This is an area where this was a patient of rheumatoid arthritis where synovitis involved this area also. This is a rare case of a peroneal tenosynovial giant cell tumor in that space. This is how micro trauma leads to ganglion formation in this region. This is how a PVNS looks like occupying the same area. So the take-home message from the case one was, number one, we got to know about the importance of subtalar joint stability. If it is not diagnosed, patient will have an unstable joint with severe pain. Suddenly the pain, there will be giving away of the foot, giving away of the ankle, and especially pain when walking on uneven surface. While deltoid and CFL are the most important ligaments sprained, whenever they are sprained, please put your eyes and see the sinus tarsi. Don't leave your report before seeing that area, because if undetected sprain over there, we will result in considerable pain and morbidity, okay? And clinical examination and history should not be missed by a radiologist. See how we took up the patient, clinically examined, clinically took the history and confirmed the diagnosis of sinus tarsi syndrome, and there was an edge above our clinician like this case. So be a clinical radiologist. Treatment is usually non-weight bearing, rest, and again, radiologist again plays a role in treatment. Just like we had diagnosed with local steroids, sometimes steroid and local anesthetics can be given over here and see if the pain is reduced. If still intractable pain after our procedure, then usually an arthroscopic debridement is done. So finished with my case number 1 and my area number 1. Let's go to my second case. This was a case of heel pain and burning. Long-standing patient has been told that you have plantar fasciitis, not resolving. Radiograph done outside only shows a calcaneal spur. Something which is one of the favorite reports of the radiologist is calcaneal spur. That is the cause of pain. Footwear was changed, not resolved. Steroid was injected in plantar fascia, still not resolved. MRI done. Ganglion was there posterior to the medial malleus, which was highlighted upon and sent for ganglion decompression. Maybe that will reduce the pain. What was done? Instead of just putting the patient on the table and taking out the ganglion over there, MR was reviewed. Clearly, we saw that over here, this is the fibula. This is actually the region where this is the medial aspect of the joint where we are seeing a part of the talus calcaneum, and over here we are seeing a significantly enlarged peroneal tendon with lot of edema around it. We put the patient on the table, examined. This was the area, there was point tenderness, patient winced, yes. So this was the area of the peroneal tendinosis. What the patient said was very important. My main problem is sensory symptoms. Over here, I have a tingling and burning sensation all over the pledial aspect of the foot, gradually travel across the entire sole. So his main point was a tingling, numbness, burning sensation. Rather, he was more worried about this rather than this pain over here. And another important history that he gave was normally when I get from bed, in plantar fasciitis, you will expect the pain to start immediately. The first step is painful. But this patient said, no, my first step is after a few steps I take, then the pain starts. These two things struck the mind of the radiologist. And the radiologist asked, how was your x-ray taken? Patient said it was taken like here, lying down. The radiologist took the patient to the x-ray area and took a weight-bearing x-ray like this, as well as heel like this, heel up, as Akanksha has already said. And what was seen, while a normal arch should be like this, the patient has a total flattened arch, calcaneal pitch is lost. In gross cases, you will also look for navicular subluxation over here. And when standing heel up, there was no correction of the heel valgus. It was remained like this. So a diagnosis of acquired pathological flat foot in this patient was made, who also had a PTT tendinosis over here, and the patient was directly sent for an NCV of the tibial nerve, and it was turned out to be positive, and the radiological diagnosis of tarsal tunnel syndrome was made. What is tarsal tunnel? Tarsal tunnel is a fibro-osseous tunnel posterior and inferior to the malleolus. It has some bony boundaries which forms the floor, which is the medial aspect of the posteromedial malleolus, the medial aspect of the talus, medial calcaneal joint, medial aspect of the calcaneum, and the entire roof is by this fibrous structure, the flexor retinaculum. What are the things that pass through the tarsal tunnel in this area? The tibialis posterior, flexor digitorum longus, the tibial vein, tibial artery, all one after the other. Tibial nerve and flexor hallucis longus. The main problem in this area is tarsal tunnel syndrome, which is caused by effect of the neural structure in this tunnel, that is the posterior tibial nerve. While it is uncompressed over here, but it is compressed over here, leading to symptoms of tarsal tunnel syndrome. As I've already said, let's see how these structures look in an MRI. The MRI shows this area. This is the posterior medial aspect of the medial malleolus. This is the PTT, flexor digitorum, the tibial vessels. This is the tibial nerve and flexor hallucis. Later on, further down, it divides into the medial and lateral plantar nerve. So this area, anatomical area, is what we are focusing on. And the primary symptom is when this small thing over here gets affected. How can it get affected? Either it gets edematous because of constant irritation, or something over here grows and extrinsically compresses this nerve. So this is another picture how the flexor retinaculum completely binds this over here, forms the roof, and finally joins the abductor hallucis muscle over here. So what are the things that can project into this area and create a compression? Number one, it can be a coalition seen well on CT as well as MR. It can be distended, inflamed tendinosis of important tendons of this year. For example, my case of PTT tendinosis, who also had a spring ligament edema. There can be gross tenosynovitis of the tendons involved, creating compression of other structures here. And in my case, what has happened, because of the persistent valgus heel, there is a lot of stretching of the soft tissues of the medial aspect. Both PTT is irritated, tibial nerve is irritated, and that has resulted in the tarsal tunnel syndrome. And what else can occupy this area? Some accessory muscles, flexor digitorum accessorius over here. A huge ganglion may sit, which compresses the tibial nerve. Initially, there will be denervation, edema in the plantar aspect of the foot. And later on, this is actually a chronic Baxter's neuropathy, where exactly the tibial nerve is not affected. It is the inferior calcaneal nerve, part of the lateral plantar nerve, which affected, and long-standing cases, there is atrophy over here. This area might be occupied by some neoplastic lesion like tenosynovial giant cell tumor, as well as there may be some effect. The nerve itself may have a soft tissue tumor along the course and get affected in this way. What is important, unlike sinus tarsi, which is a deeper structure, this is a very superficial structure and very, very nicely seen in ultrasound. All the flexor retinaculum can be seen, the muscles can be seen, the tibial nerve seen. See how beautifully the division of the medial and lateral plantar nerves can be seen. This is the area of CPPD where there is calcific tendinitis in that region. This is the area. This is one case where there was a fluctuant swelling over here, and the probe was put, and what we did we see a soft tissue lesion, and this is the medial and lateral calcaneal nerves. When color Doppler was, this is a vascular malformation in this area, causing extrinsic compression of the nerve and causing this. So the role of ultrasound here is very important, more than MRI, because these are superficial structures, beautifully seen on ultrasound. Again, like sinus tarsi syndrome, as I said, there can be infiltration of local steroid and lignocaine in perineural area, or a hydrodissection over here being performed here, or also flex whenever there is gross tenosynovitis of the tendons over here creating the problem. That also can be dealt by tendon sheath injections. This is how a beautiful nerve again looks in this area, as we have spoken. So take home message from my second case was that there is an important area in the posterior medial aspect known as tarsal tunnel, and the problem within which creates morbidity is called tarsal tunnel syndrome. We have learned about the anatomy. We have learned that ultrasound is very important because superficial structures can be easily dealt very nicely, and not only that, interventions can be performed at the same time. We also have got to know that irritation of the nerve causes typical symptoms that the radiologist needs to know, that it is the distribution of the sensory symptoms which catches the diagnosis. And in general practice, acquired pathological long-standing uncorrected flat foot is a very important, most important cause of tibial nerve stretching leading to tarsal tunnel syndrome. In our case, what we did was we took the patient back and we performed a lateral view radiograph on weight bearing. We reviewed the MRI. We reviewed the patient, took the history and found out that this is not a typical history of plantar fasciitis. We saw the tendinosis over there. In fact, the MR also revealed that there was a spring ligament sprain, and the diagnosis of acquired flat foot, pathological flat foot undetected has caused this problem. And a tendon sheath infiltration of anesthetic and steroid was done, and the patient is doing fine. If the patient doesn't do fine, then of course a tarsal tunnel release surgery is required. So before I finish my lecture, I have to say that all my ultrasound images has been given to me by my dear friend, Dr. Ankit Shah. and the other cases, many are there from Radiopedia for completion and understanding of the same. I want to thank entire MSS family. I will not call it a society, because first time when Dr. DK told me, I was like, should I take this topic? He said, please go ahead. We'll provide images, but don't refrain from speaking. Thank you, Dr. Mahesh, for your support, Dr. Jairaj, for your support. I end my lecture with my recent, this is my complex Durga Puja, to bless all our MSS viewers, MSS society, and I hope to see you all in Jaipur very, very soon. Thank you very much.
Thank you, Dr. Sajita, for showing the case-based discussion. So that's a very the important aspect and the way we can learn much better way. So thank you very much, and you showed very two good important cases of sinus tarsi as well as the impingement, the tarsal tunnel. Thank you very much. We have a question, but because of lack of time, probably we'll see at the end of the session we can have some questions. So now we'll move to the next topic that is will be taken by Dr. Bhanupriya. And Dr. Bhanupriya, she has more than 18 original research papers. She's working as assistant professor and consultant radiologist, Ram Manohar Lohia Institute of Medical Science, Lucknow, where we had the last MSS meeting, annual meeting this year only. And she has interest in musculoskeletal imaging as well as the other imaging. She's a member of Speaker Bank at ICRA. She is a fellowship of at NIMHANS and PK Haldar Traveling Fellowship. And she was selected for the Invest in Youth program by the European Congress of Radiology. So thank you very much, Dr. Bhanupriya, and over to you for your presentation.
Thank you so much, sir, for the kind words. At the onset, like to thank the MSS Society, respected Mahesh sir, Dharmen sir, and Jairaj sir for the opportunity. And let's start with our topic of angry ankle, the metabolic and rheumatologic conditions that cause it. So so this is how clinically the picture would be of a patient who has a chronic swollen and an inflamed ankle joint, and we'd be studying the gamut of findings. At the onset, just for a quick recap of the anatomy that we have been discussing since morning. So posteriorly along the ankle, we have the flexor group with the posterior tibialis posterior, flexor digitorum and flexor hallucis tendon going posteriorly. Laterally, and posteriorly we have the tendo Achilles, and laterally we have the peroneus brevis and longus tendon, the longus tendon coursing around the inferior aspect and inserting at the inferior aspect of the tarsal and metatarsals. Anteriorly we have the extensor tendons of tibialis anterior, extensor hallucis longus and extensor digitorum longus. The important ligaments are the syndesmotic ligaments, the medial and lateral ligament. The syndesmotic would be the interosseous, the anterior and the posterior tibiofibular, and the transverse tibiofibular ligament. Laterally, we have the anterior and posterior talofibular ligament and calcaneofibular ligaments, and medially we have the deltoid ligament. So this is schematic. And a quick recap again of the anatomical description. So this is the anterior tibiofibular ligament. This is the anterior talofibular ligament between the talus and the fibula. Along the lateral aspect here, we see the posterior tibiofibular ligament, the anterior talofibular ligament, calcaneofibular ligament, and the peroneal tendons within the sleeve. Here is a zoomed in view of the peroneal ligaments, the peroneus brevis inserting in the fifth metatarsal and the longus going ahead. And this is the posterior talofibular ligament. And the deltoid ligament, as we discussed in the previous lectures, is one of the most strongest and located along the medial aspect of the foot. And this is the quadrangular shape of the deltoid ligament that's above the tibialis posterior tendon, and it forms a quadrangular shape, and there are superficial and deep layers to it that we have discussed in the previous lectures. Coming on to the metabolic conditions that involve the joint. So the most common being gout. Gout is a crystal arthropathy due to deposition of monosodium urate crystals that are famously negatively birefringent on microscopy, and they produce periarticular soft tissues. The synovial fluid is generally a poor solvent for these crystals. Therefore, it crystallizes at the body temperature, and these crystals activate. They are chemotactic and they activate the complement pathway. So the normal course of the disease, gout initially can be asymptomatic, just causing hyperuricemia in the blood picture. Then after the precipitation process begins or starts, it can suddenly come to us as an acute gouty arthritis or acute exacerbated. Between the attacks, there is a dormant period, also we can say it, intercritical gout, or between the acute attacks. Then as the disease progresses, there can be chronic deformity, and what it forms is tophi, and these chronic tophaceous gout becomes a chronic pathology. Later to it, it also causes neuropathy or gouty neuropathy. So what does it show on X-ray? Initially on plain radiograph, it can only be seen as a soft tissue swelling. In chronic condition, the soft tissue or intraosseous masses can be seen. They can be non-demineralizing erosive arthropathy, or with erosions that are well-defined, sclerotic, and they have overhanging margins. Extra-articular erosions or intraosseous calcifications can also be seen. Joint space is classically preserved till until advanced stage, and that helps us differentiate it from osteoarthritis. And basically, radiograph, it shows very late, so all the other modalities become more important. And classically, we can also see some dermal calcification as a part of gout also. So when you're seeing some skin or dermal calcification, you don't only have to think about dermatomyositis, it can also be a component of gout. So gout classically is a polyarticular but asymmetric arthropathy, and it produces radiolucent lesions that have sclerotic margin, as well as edges are overhanging, and we see a gross soft tissue swelling, right? And so the overhanging edges, here again we are seeing some sclerotic margin along the overhanging edges. So it doesn't need to be symmetric. Sometimes it can cause metatarsophalangeal, or first metatarsal is classically involved in most cases. Now, apart from X-ray, how we see it on ultrasound. So patient can present, so like patient presents with painful and swollen joint, most commonly, firstly, after ruling out any acute trauma or any acute, fracture, with X-ray, it's generally sent for ultrasound. So in this case, tendo Achilles was involved, and what was seen on X-ray was this fusiform dilatation of the tendo Achilles. On ultrasound, the fibrillar pattern was heterogeneous, and we were seeing some echogenic foci giving fluffy appearance. They are theoretically said to be the crystal depositions themselves, and there's associated synovitis. And on putting color Doppler, we see these patchy uptake of the inflammatory tissue in the superimposed in the swelling. This is another case. So here again, with the first metatarsophalangeal joint, here we are seeing some soft tissue swelling, as well as overhanging edges and bone sclerosis and erosion. And see, classically the joint space is preserved, and also the surrounding joints seem to be okay. And on ultrasound, we are seeing this soft tissue pannus-like thickening, and that was showing significant increased vascularity on color Doppler. So mostly the diagnosis is made either by biopsy or on aspiration and demonstration of these crystals. Clinically, we can see and suspect, and radiologically we can pick up the findings, but again, to call it pathognomic it's not pathognomic, right? On ultrasound, bone erosions are more easily demonstrated on ultrasound in early stages, because X-ray, it only becomes evident on when it's more obvious, right? So on ultrasound, it gives what is known as double contour sign. It is produced because the hyperechoic and irregular band over the superficial margin of the joint cartilage. So that is produced because of the deposition of the urate monosodium crystals on the surface of the hyaline cartilage of the joint. That causes increase in the thickness. Apart from it, ultrasound will show us the synovial thickening that can be hyperechoic. Sometimes it could be smudgy or cloudy. Bone erosions can very well be seen as step changes, and then that should be demonstrated on two perpendicular planes, and tophi or soft tissue swelling that are variably calcified can also be very well seen on ultrasound, and on Doppler it's shown increased vascularity very well. So this is what the demonstration of a zoomed in view of a cartilage, right? And here it's showing a double contour sign because there's potential deposition within the cartilage also. On very well demonstrated X-ray, it can also be seen as chondrocalcinosis. CT is classically of not much value, but it helps demonstrate the extent of articular and subarticular tophi better. Dual energy CT is of much more importance than plain CT, and it demonstrates masses of approximately this higher Hounsfield unit, approximately 170 HU unit is the density of these nodular tophi that are deposited in gout. So that, and on MR again, the tophi and the erosions are well seen. If there's surrounding tendon or ligament involvement, then that can be better seen. Gadolinium enhancement to some extent does show disease activity. If there's joint effusion, that will be better demonstrated on MR, especially on post contrast, right? So that can also help us, although that will be also seen on ultrasound. So that can help us, aspirate and guide the treatment for after demonstration. So again, recapitulating, so tophi are actually the aggregate amorphous urate crystals that with protein matrix that produces surrounding intense inflammation. So on MR, they've seen as soft tissue masses of variable T2 intensity. Classically on T1, they are hypointense and can be homogeneous. On T2, they are more heterogeneous. They show peripheral or nodular enhancement, and this enhancement basically depends on how much of it is calcified, how much of it is inflamed, and it also shows disease activity. Tophi can occur anywhere in the joint. So this is of importance that it can be intrasynovial, it can be intraosseous, within the tendon, within the ligament, adjacent to the joint, or adjacent to the ligamentous structures. Now, synovitis, synovial membrane under normal circumstances is practically imperceptible, or if at all, seen as less than 1 mm thickness. In synovitis, especially of such pathologies like gout, the synovial will be nodularly thickened at least of more than 2 mm thickness, and it would show variable enhancement. And on the tophaceous material, again, that would be of heterogeneous, and it can be intermediate to low. Again, the low is because of the extent of fibrosis, and calcification that are present within it. The subarticular bone marrow edema can very well be demonstrated on this MRI with joint effusion. So why post-contrast MR defines effusion better is it demonstrates the synovitis effusion complex differently. Means you can differentiate what component of the thickness is synovitis and what component of the thickness is purely fluid, right? So that is of importance. And bone erosions can also be better seen, especially on T1 weighted images, right? So this is a dual energy CT that's demonstrating these erosions as, subtalar and talocalcaneal erosions and tibiofibular erosions, and they are seen as on dual energy green color coded these depositions. So these are the tophaceous gouty depositions. Here again, we are seeing similar deposits in the first metatarsophalangeal joint. See these sclerotic margin erosions with overhanging edges that are classically defined for gout. Here again, we are seeing a big component of tophi. So this is a large soft tissue swelling seen on simple X-ray itself. On CT, so here on CT, again, the soft tissue component is correspondingly seen. And on MRC, it's predominantly more hypointense. It's got more calcific component to it that makes it more perceptible on X-ray. So this is a coronal and a sagittal image. Again, we are seeing some erosions with these soft tissue lesions that are having, bony erosion as well as intermetatarsal extension, right? And so that is what it can have. It can involve any component of the joint. Here, it's just lateral to the fibula. A large exophytic type of predominantly soft tissue lesion here is seen, and it's not causing that much of bony erosion in this case. This this tophi. So this was again T1 hypo, heterogeneously T2 hyper, and classically peripheral post-contrast enhancement. So this is again similar. So this is along the plantar as well as the dorsal as well as the plantar aspect of the foot. It is also having some intraosseous component in the metatarsal head in the bone. So in next case also we are seeing the erosion. So this is obviously the most common site that's through ages defined and described in gout, the first metatarsal head, and how it the variable amount of erosions it can produce at the site. So this is another case of where we are seeing, apart from the erosions at different joint spaces, like talonavicular, that is significantly involved in this. But here in tendo-Achilles, along tendo-Achilles, a soft tissue, this thickening was seen that was proved to be tophi. So this again has an intraosseous component, and that's showing some component of activity or enhancement and was causing adjacent bone erosions. This tophi is classically intraosseous. So it's not pathognomic. It can be confused, or it can actually Brody's abscess differential should be given also, but this was proven to be gout. So this is another case. Here it was having intraosseous tophi with surrounding bone marrow edema. Not much of tendon or soft tissue involvement was seen in this case. So similar, this is so this is within the joint, right? Intermetatarsal and along the second metatarsal joint apart from the first. So this is a little atypical, but this is also gout. Now coming on to the second condition that is metabolic and involves ankle joint is Charcot's neuropathy or neuropathic joint. So what happens is there is progressive degeneration or destruction of the joint. So it is because of the abnormal pain sensation or proprioception. The most common condition that is affecting in all over world is actually diabetes mellitus, right? The diabetic foot. Apart from it, some spinal conditions, so that cause tract interruption, right, can also be causing this, like syringomyelia, any tumor. So it could be peripheral nerve tumor from the cord, or it could be the spinal cord tumor, primary, any cord trauma, or any of the conditions that involve the cord, like leprosy or polio, multiple sclerosis. This neurosyphilis and TBs don't occur now. So chronic steroid use, even systemic chronic steroid use, becomes more prone for developing Charcot's joint or neuropathic joints. So how does diabetes cause Charcot joint? So one component is it causes osteomyelitis and suppurative inflammation with the bone destruction. So this occurs. So this affects the pressure points in the forefoot and the hindfoot. So metatarsal and phalangeal heads are predominantly the located site for abscess formation or wound formation, or posteriorly along calcaneus. It can also directly cause neuropathy, and the neuropathic joint occur because of the bone destruction. So intertarsal joints are dislocated. So because of the dislocation of joint, faulty weight bearing and access of weight bearing occurs. So this causes joint disorganization, dislocation, and eventually destruction with erosions, right? So here we are seeing near completely displaced talus bone. There's some soft tissue enhancing component adjacent to the talus also, and posteriorly along the tibiocalcaneal aspect also. On STIR images, extensive marrow edema was seen, and this pannus was also showing edema, and tendo Achilles was also showing frank rupture. And here on T1 also we're better appreciating the cortical irregularity. There's also stress fracture occurring within the calcaneal bone. So this is like dry type. So means the second component that causes joint disorganization or disruption. Now it can, like we said, that it can also cause suppuration because of osteomyelitis, right? So here we are seeing abscess cavity in the tarsometatarsal joint space. That's showing, enhancement on post-contrast injection, and some component of non-enhancing bone is also seen that actually corresponds to bone necrosis that is happening, and it can involve multi-compartment tendon involvement can be seen. So here again we are seeing so now coming on to the next condition, which is ochronosis or alkaptonuria. So when ochronosis comes, you classically remember the spine and the rugger jersey spine and spinal involvement that we encounter. However, this one, it can also have tendon involvement. So when it involves foot, it causes most commonly near complete rupture of the tendo Achilles. So like it was very well discussed previously, that whenever there is tear, we should label it if it's partial, if it's complete, how much is the retracted distance, and how are the edges like. If there is any associated complication like abscess formation or any other abnormality, that the onus is upon us. Like for in this case, in the intermuscular plane, there was this fluid condition. There was this actually fluid with fluid level. It was an acute hematoma. Now the next condition that can involve
Bhanupriya, Doctor, sorry.
Yes, sir.
Dr. Bhanupriya, sorry to say, but can you wind up because the time is up?
Yes, sir. Yes, sir.
You can show the images, please.
Yes, sir. So in psoriasis, again, we are seeing these marginal erosions and penicillin cup deformity can be seen. So that is, in this case, corresponding with the bone scan uptake. Here again, we are seeing, so this fibular deviation that occurs classically in the foot, and here severe joint destruction with the penicillin cup deformity and fibular deviation was seen. Here, the periostitis that is there is classically called fluffy periostitis, and eventually it can lead to ankylosis or fusion at the joint space. Rheumatoid is another condition that is causing synovitis that targets the bare area of the joint where the cartilage is not there and the synovium is directly in contact with the bone. So as it progresses, it causes synovitis, erosions, and eventual ankylosis. So this was intraosseous, actually suspected Rudy's but proven rheumatoid. Here rheumatoid classically affects the medial aspect of the metatarsal heads. This also causes fibular deviation, but classically the medial heads from first to fourth metatarsal are affected. So this is another image of pannus showing this post-contrast enhancement. So thank you.
Thank you, Dr. Bhanupriya, for showing the metabolic conditions and the arthritis cases. So, and gout was so important, and you have showed so many cases. So thank you very much. We don't have any questions, so we'll go to next speaker. And the next speaker is Dr. Harmeet Kaur. And she will be speaking on the opening the Pandora box, non-traumatic osseous lesion of talus and calcaneum. Can we have her CV, please? Dr. Harmeet, are you there?
Good morning, ma'am. Dr. Harmeet, ma'am. I made her the presenter.
Okay. Let's see, there's.
Hello. Hello.
Sir, can we move to the next session, sir? In the meantime, Dr. Hamid will join.
Yeah,
Okay.
yeah, that's a better
Dr.
way.
Stanzin is, I'm sorry.
Dr.
Yeah, Dr.
Stanjin, are you there? I can see her name here, Dr. Stanjin.
Yes, hello.
Oh, okay.
Yes,
Yeah.
yeah. Okay, I can actually start. I'm ready with my presentation.
Sure,
Please
good.
go
Good.
ahead.
Can you show your slide?
Yes, sir. 1 second. I'll just share my screen.
Yes.
So shall I start?
Just hold. Yes. So just to introduce Dr. Stanjin, she is currently the assistant professor at All India Institute of Medical Science, AIIMS Delhi. She did the fellowship of MSc Radiology from PGI Chandigarh, and she's executive member of Delhi State Chapter of IRA. She delivered a lot of lectures as well as she conducted the MSc ultrasound workshop. And so thank you, Stanjin, and over to you for your topic.
Thank you so much, sir. First of all, at the outset, I would like to thank Mahesh Prakash sir, Dharmender sir, for giving me the opportunity to be a part of Voice of Young MSS. Today, I'll be talking about adult acquired flat foot. And since it's an extensive topic and we have limited time as I see it, I'll quickly start off with my lecture. So, flat foot can be developmental or acquired. We should know that infants are when they are born without an arch, and that is physiological. Arches will develop over the next 4 to 5 years of age. And also the fact that around 10 to 15% of the population never fully develop an arch at all. And majority of them usually do not have any symptoms also, and they do not need any treatment. However, some of them do develop, especially when they're associated with certain laxity syndromes or coalition, then that is the developmental type of flat foot. But the focus of my lecture today is the acquired type of flat foot deformity. And this is, 1 second, so I'll just put on my pointer. So acquired flat foot is when the patient usually develops a normal arch, and then at a later stage, due to various risk factors like these, it leads to multiple micro trauma to the posterior tibial tendon, and that further repetitive loading makes it even worse, and eventually it leads to a collapsed arch. So that is the acquired form. And yeah, we'll discuss the same. The lecture will be discussed under the following contents. So starting with the normal anatomy. This is the medial longitudinal arch. We have 3 intersecting arches. The medial longitudinal arch, which is the more important one. Then we have the lateral longitudinal arch and the transverse arch at the level of the tarso-metatarsal joints. So this bony arch alignment is stabilized by various, again, dynamic as well as static stabilizers. The most important of them is the posterior tibial tendon, which I'll refer to further as the PTT. So this is just another table from this radiographics article, which summarizes all the stabilizers, their structure, function, and the signs of failure. Starting with the posterior tibial tendon. So posterior tibial tendon, the tibialis posterior muscle is a component of the deep posterior compartment of the calf, and it forms the tendon just proximal to the ankle joint. And there are some few peculiar features about the posterior tibial tendon. That is, one, as relative to the size of the muscle, the size of the tendon is relatively small. So it just brings about movement across the midfoot and the forefoot region with just minimal, approximately 2 centimeter of excursion only. That is why any change that occurs within the tendon will have a bigger impact. Even if there is a small tear, it will have a significant amount of dysfunction associated. A few other features are that it takes a very steep turn. It almost turns from a vertical position to a horizontal position. in the retromalleolar groove region, and in that particular site it has to pass through this narrow groove. And one more point to note is that in the mid portion of this tendon, it is a watershed area. That is, there is relatively poor blood flow to this tendon, which makes it very highly susceptible to ischemic damage. So just like ischemic damage in the brain, like stroke or the myocardial infarction, PTT dysfunction is also a senescent disease, and hence it is seen more commonly in elderly individuals, commonly in middle-aged or slightly older elderly females. So PTT has an important role in the gait cycle. I'll briefly describe the gait cycle so that the biomechanics are easily understood. So gait cycle, for example, for the right foot in this example is nothing but a series of events that take place during a single stride. And a single stride is composed of two phases, a stance and a swing phase. Stance phase is when the foot is weight bearing, and also the weight of the body is pushed forward on that foot. That is the stance phase. And swing phase is when the foot is offloaded. So this is another schematic diagram. We can see this is the talus and this is the calcaneum. The posterior tibial tendon brings about inversion and eversion. This is inversion and eversion of the foot, which is brought about at the level of the subtalar joint. Okay, but it does its magic actually at the transverse tarsal joint. So transverse tarsal joint is nothing but the mid tarsal or the Chopard joint, which is seen between the talus and the navicular and the calcaneum and cuboid. So in this, okay, so this is the talonavicular joint articular surface and the calcaneum cuboid. So to better understand the biomechanics, just we can use the hinges on the door analogy. Imagine a door with two hinges, and when they're well aligned to each other, we can easily open and close the door, right? So now imagine if one of the hinges is angulated or tilted relative to the other. Now the door will not be able to open or close it very easily. It will be kind of fixed in that position. So similarly, over here also, in the eversion, when the foot is in eversion, the axes along these two joints, the talonavicular and calcaneocuboid, are parallel and aligned to each other, which makes this mid-tarsal joint quite mobile. So it can easily move about. But what PTT does it brings about inversion, that at the level of the subtalar joint, which draws this calcaneum more medially, and hence now the joint line is these two joint lines are not parallel anymore. So this kind of brings about the locking of this joint, of the mid-tarsal joint. Okay, so what is the significance of this is that in the late phase of the gait cycle, this is during the propulsion phase, especially during the propulsion phase, the gastrocnemius contracts, gastrosoleus will contract and bring about plantar flexion at the level of the ankle. So simultaneously, the posterior tibial tendon will also contract, and that will bring about locking of the mid-tarsal joint. And this locking of mid-tarsal joint will act as a rigid lever through which the plantar flexion is smoothly transmitted to the metatarsal head, and hence the person can propel forward. Now, that is what normally happens. Okay, so if the posterior tibial tendon is not functional anymore, then even on weight bearing, the foot will still remain in eversion, and the two joint axes will remain parallel to each other, and that will cause the mid-tarsal joint to remain mobile, and it is not fixed. So again, during the propulsion phase, when the gastrosoleus will contract, there will be plantar flexion, but now that we don't have a rigid lever through which it can be transmitted, the plantar flexion will be instead transmitted to the mid-tarsal joint, which will itself undergo plantar flexion like this, leading to descent of the talar head as well as the calcaneal anterior process. And then further, when the patient bears weight, moves about more, there will be more descent and more damage to the soft tissue structures around the medial aspect of this joint. So it just starts off like a kind of a vicious cycle, and further flattening of the curve occurs. So that is one of the things that happens when there is posterior tibial dysfunction, that is flattening of these arches. Secondly, one thing we can remember here is that talus per se does not have any muscular attachment of its own. But the posterior tibial tendon has its major attachment on the navicular bone, the cuneiform, and then it spreads out, gives attachments to these cuneiforms in the second and the fourth metatarsals. So what it does it when it contracts, it kind of draws all these structures medially relative to the talus. So talus is not really mobile unless the ankle joint is moving. So talus remains at the same side, and these structures are drawn by the pull of the posterior tibial tendon. But when there is dysfunction of the posterior tibial tendon, there is unopposed action of the peroneal tendon, and hence, because of its dysfunction, the forefoot and the midfoot structures will undergo abduction relative to the talus. So there is forefoot abduction, and in that process, it also leads to uncovering of this articular surface of the talar head. So these are some of the deformities. And secondly, you can remember from this diagram that whenever PTT contracts, it brings the calcaneum more medially. So again, imagine if there's a dysfunction, then it will go more in the valgus position, and on weight bearing, it will further undergo valgus. So there will be a hindfoot valgus deformity as well. So these are the series of deformities that occur whenever there is PTT dysfunction. So to look for the alignment or assessment of this alignment is best done on X-rays. Why X-ray over CT and MRI? Because the other two cannot be acquired with the patient weight bearing, and weight bearing is extremely important in this case because many of the flexible deformity will not be apparent without loading. Okay, so in X-ray, it's also simple to acquire also. And the whole idea behind acquiring these X-rays and doing these calculations is that we want to see if there is, we want to see the severity of the longitudinal arch flattening, and also look for other deformities that I just described and see how severe they are. For example, if you want to see the longitudinal arch flattening, then obviously we'll prefer to do a lateral view, right? And similarly, to look for this hindfoot valgus deformity and the talar head uncoverage, etc., we would prefer to do an AP view. Okay, starting with the lateral views. It looks like you're sharing. Oh. Okay, so starting with the lateral view. We are trying to assess the arch flattening. So we know that there's a medial and a longitudinal arch. So assessing the medial longitudinal arch using the medial longitudinal arch structure. So we'll draw a line along the long axis of the talus and the first metatarsal. So in an ideal scenario, these two should be almost parallel to each other. That's why the angle will be almost zero. Okay, but in case of flat foot deformity, like in this case, we can see because of the inferior descent of the talar head, the angle between the two will be increased. Similarly, assessment of the lateral longitudinal arch can be done with the help of calcaneal fifth metatarsal angle, where again we'll draw a line along the inferior surface of the calcaneum and along the inferior surface of the fifth metatarsal. Normal range is 150 to 165, and because of the flattening, obviously the angle will increase. Besides that, now we are trying to assess the inferior descent of the calcaneus. When we do it with in relative to the position of the horizontal line, then it is known as the calcaneal inclination angle, and normally it is around 20 to 30, and in flat foot, obviously it will decrease. Similarly, we can also measure the talocalcaneal angle. Talocalcaneal angle is used in other pathologies as well, but again in flat foot also we can do use this angle as an assessment of the inferior descent of the talar head relative to the calcaneum. So these were the arch flattening parameters that we can assess on X-rays. Now coming to the assessment of the hindfoot valgus and the talar uncoverage on AP views. So this is a normal X-ray for comparison, this is abnormal. Don't focus on this, we are just trying to show the alignment right now. So again, talar's first metatarsal angle. These are the structures that form the medial longitudinal arch. Again, assessing the same, these two should be almost in a parallel line. So what happens again, because the forefoot abduction, the angle will obviously increase. Okay, so this is also one important parameter that people assess to assess the severity of the deformity is the talonavicular uncoverage angle. So we'll just draw a line along the lateral margin of the articular surface of the talus and see how much percentage of it is uncovered on the medial aspect. This is again another extension of the same. Again, we are trying to just see how much of it is uncovered, but this time with the help of an angle, we'll just draw a line along the lateral edges of the articular surface of the navicular bone and the talus, and these should obviously ideally be congruent, and that's why the angle should be almost 0. But again, in flat foot deformity, because of the peritalar subluxations, it will increase. Okay, and one more deformity that we discussed is that with the flat foot flattening of the arches, we see hind foot valgus also. So for that, we use this specialized view known as the Salzmann view. We draw a long line along the long axis of the tibia and also along the calcaneum. Again, in an ideal scenario, both of these should be in almost a parallel line. But again, because of the valgus deformity, the angle will be increased. So this is a compilation of all the angles that I just described, the important ones. This is just to show that not just X-rays, but CTs also are sometimes nowadays done under weight bearing, which can give definitely more information. But since this is not available everywhere, we'll just skip it. Okay, coming to the other imaging findings of PTT dysfunction, like tendon involvement anywhere else in the body also, it's always seen either as tendinosis or there is tenosynovitis, and in the later stages there can be partial or complete tear. And this assessment can be done using both ultrasound or MRI. So I'll just show representative few images of the patients that I had seen. So this patient had flat foot deformity due to PTT degeneration or tendinosis. Tendinosis everywhere else also will appear the same. So the tendon will appear bulky and heterogeneous will also appear heteroechoic. This is the longitudinal axis view of the same tendon, where we can see the tendon is bulky, heteroechoic, and also there is some fluid signal within the tendon sheath and some amount of synovial thickening as well. So this dysfunction can be associated with some risk factors, like I said earlier. So sometimes systemic illnesses like rheumatoid arthritis can also cause this dysfunction. This patient had flat foot, and also she was a known case of rheumatoid arthritis. She had significant tenosynovitis of the posterior tibial tendon, along with other tendons and joint effusion and edema, etc. This patient just had dysfunction and some amount of tenosynovitis, but the tendon appears more or less preserved. So this patient had a pre-existing posterior tibial tendon dysfunction, but because of the excessive pain that occurs along with this condition on the medial aspect, she had undergone some steroid injection into the tendon, and which has led to a complete tear of the tendon. A section through the proximal aspect shows the tendon appears bulky and retracted, and another section through the tear area, we can see that there is no tendon material visible, only some fluid signal is seen in the same. And this is showing the torn distal retracted fragment of the same. Again, the same patient, ultrasound also can show the similar findings. This is the torn retracted proximal fragment, and the torn part is filled with fluid. Okay, so normally the anatomy has been discussed at length already, but yeah, the posterior tibial tendon lies in the retromalleolar groove, and sometimes it can get dislocated due to injury to the retinaculum. Here, this patient had again flat foot deformity. She had an associated posterior tibial tendon dislocation, which is dislocated anteromedially. This patient had a accessory navicular bone, which is present posterior-medial to the navicular tuberosity. And again, having said that, it's a very common finding, and not every patient with navicular accessory bone develop a flat foot, but it is seen as an association with patients with flat foot. The hypothesis that they've given why it can cause is that because it is present slightly proximally, so it kind of decreases the total length of the tendon, which may again impact the function. Okay, so we have talked about the posterior tibial tendon. Now we'll talk about some other secondary stabilizers, and I don't think I need to go in so much detail because all of these structures have been discussed here already beautifully by all the other speakers. Briefly about the spring ligament. This is the second most important stabilizer after the posterior tibial tendon. So when the posterior tibial tendon gets affected, next in line is always the spring ligament, which gets injured. Why? Because obviously there will be inferior descent of the talar head. So spring ligament forms this hammock-like structure which supports the talar head and prevents its descent. But because of the deformity, there is inferior descent of the talar head, which causes further strain on the spring ligament. So that is the whole idea. And yeah, there are some criteria for the measurements. Less than 2 millimeters is also abnormal. That could suggest that the tendon is either partially torn, only some fibers are remaining, or it could just represent attritional changes over in cases of chronic injury, or more than 5 when the tendon is either contused or again degenerated. So spring ligament is best assessed on the coronal images. And one thing to remember is that it will always be a structure that will separate the talar head from the posterior tibial tendon. So always look for the section, coronal section, where we see the talar head, and look for the posterior tibial tendon. And something that is intervening between the two is always the spring ligament. So in this patient, we can see this is the spring ligament, and there is some fluid cleft also. And within the ligament itself, we see some hyperintense signal. And the structure that connects the tibia to the spring ligament is the tibiospring ligament, which also appears to be injured in this case. In fact, even the posterior tibial tendon is showing some intersubstance hyperintensity. So this patient also had flat foot involving all of these support structures. This was another patient with the one with the posterior tibial tendon complete tear. She had severe deformity, and we can see this was her posterior tibial tendon. This is her talar head, and there is nothing intervening between the two, suggesting a complete tear of the posterior of the spring ligament. Next is a sinus tarsi, which houses the cervical ligaments or the talocalcaneal ligaments. Again, in flat foot deformity, the talar head descent occurs. The space between the two, this potential space also gets reduced, and the normal fat signal is completely replaced by some amorphous appearing T1 hypo and T2 hyperintense signal, suggesting the diagnosis of sinus tarsi syndrome. Okay, coming to the next secondary stabilizer, the deltoid ligament. Again, it has been described already, but what I want to point out that as far as flat foot deformity is concerned, it is the superficial component of the deltoid ligament, that is the tibio-navicular, tibiospring, tibiocalcaneal ligaments, the superficial ones. They are more important in resisting the peritalar subluxations. So in earlier stage, when the disease is limited to the midfoot region, it is these tendons that ligaments that get affected. But when there is severe deformity in the midfoot, and now the changes have shifted to the ankle joint, that is when the deeper component, that is the posterior tibiotalar ligament, will get affected. So this is just another example to show the involvement of the tibiospring ligament in one patient with flat foot. And this is just a representative. This patient did not have flat foot. It's just to show how a involvement or partial tear or involvement of the deltoid ligament will look like. Similarly, on ultrasound also we can have, this is normal, this is abnormal. So we have to look for it just deep to the posterior tibial tendon in the posterior aspect. And we see this nice fan-like appearance, which is not seen in the torn deltoid. Okay. So one more structure that maintains the arch is the plantar fascia. There are various theories.
Dr. Stanjan, can you summarize?
Yes, I'm left with just few slides only.
No, just
So
okay.
plantar fascia is also important. One thing is like, again, finding of plantar fascia involvement will be similar to at any other place, but per se involvement of plantar fascia will not cause development of flat foot. It is just that in congruence with all the other stabilizers, it can further contribute. Clinically, patient will have pain along the medial aspect, along the posterior tibial tendon excursion region. And yeah, we can clearly see the deformity. The arch is completely lost, and there is elongation on the medial aspect. Here we can assess that there is hindfoot valgus. Besides that, the too many toes sign is just assessment of the forefoot abduction. So normally we see only the fourth or the fifth toe. We start seeing many toes when we see from the back. This patient had it on both the sides, so we can see too many toes on both the sides. We can even ask the patients to do this single limb and the double limb heel raise test, where we try and see if the deformity is getting fixed. If it is getting fixed, that means the deformity is flexible, and also the tendon is functional, and we can try and fix the tendon. Okay, this is the test to look for any gastrocnemius contracture, because if there is associated gastrocnemius contracture, repair of the other tendons can be done, but along with that, there should be some gastrocnemius lengthening procedure which should also be added. So this staging system one must remember, because this also helps us decide what is the treatment. So I'll just say briefly is stage 1 is when there is no deformity per se, it is just involvement of PTT, there will be dysfunction of tenosynovitis. Stage 2 is when there is deformity, but there is no arthritis yet. And so far we're talking about the midfoot joints. There's no arthritis, but there is deformity, and that just shows that it is still flexible. Stage 3 is when the midfoot joints have become arthritic and it is fixed. And stage 4 is when the midfoot is already involved, and now the changes are seen at the ankle joint. So in management, of course, for acutely for the pain, rest, doing anything that is worsening the pain, using these shoe inserts or custom-made medial arch supporters can be used and associated with physical therapy in case of mild and moderate diseases. In severe cases, one might need to do some surgeries. In the early stage, stage 1, when there is only tenosynovitis, tenosynovectomy can be done. Further repair of the tendon can be done, and to strengthen the tendon, it can be attached along with the flexor digitorum longus. Various osteotomies can be done to change and correct the alignment. And once the joint has gone into arthritis, then simply arthrodesis can be done. So these are various surgeries that one can do. This is my last slide. This is just to recall and tell people that the fastest man on earth, he also is flat-footed. So turns out that having a flat foot does not affect your speed. And also one of the most beautiful people also are flat-footed. Thank you.
Thank you, Dr. Stanjan, for showing the excellent the demonstration and the images about the flat foot. Obviously, it's a long topic, and you need to summarize it and you properly summarized. So thank you very much again. So before the quiz, the last presentation is by Dr. Harmeet Kaur. Dr. Harmeet Kaur, are you there?
Yes, sir.
Dr.
Good
Harmeet,
afternoon, sir. I am there. I'm trying
please.
to share, but there's a bit glitch, sir. Please give me some time.
The bottom button, ma'am. Share content.
Yeah, I'm sharing, but
Okay, ma'am. I'll share in your place. Is that okay?
my share button, it is not like highlighted. I'm trying to share continuously.
That's fine, ma'am. I will share this thing. Content, you can just say the next slide. So it will
Yeah,
be
yeah,
easier
yeah.
for you.
Fine, fine. That would be okay, I think. Please display my PowerPoint.
So the next speaker is Dr. Harmeet Kaur, and she is associate professor in the Department of Radiodiagnosis, All India Institute of Medical Science, Bathinda. She is a fellow of International Medical Science Academy. She is honored with the best presentation in the MSS 2014. She has been the faculty speaker in the state as well as national platform. And she has a publications and the chapters and with a special interest in MSK radiology, women's imaging. So thank you, Dr. Harmeet Kaur, and over to you for your presentation.
Thank you, sir, for kind introduction. Can you see my cursor moving?
Yes.
I think that is it moving, sir?
Yeah, I can see it. Yes.
Okay, fine. Next slide. So I'll be speaking on the topic non-traumatic osseous lesion of talus and calcaneum. I'll be covering this anatomical variants, congenital anomalies pertaining to talus, calcaneum, followed by infections and bone tumors. Next slide. So brief about anatomy. So these are the like medial and lateral views of the bones in which we can see the talus. Can you see my cursor over talus?
No, ma'am, because I have the presentation. I
Okay,
don't think we can do.
fine. Okay, got it. So this talus, it beautifully sits over calcaneum, shares an articulation with calcaneum by a subtalar joint. Sorry for the glitch. I'm not. I won't be able to like show the images with my cursor. Please bear with me. So these two bones, they form the subtalar joint, the posterior subtalar joint, middle facet subtalar joint, and anterior facet. In this posterior view in the bottom, I would like to show the importance of this posterior process of talus having two tubercles. This is a lateral tubercle and this is a medial tubercle, which forms a groove through which flexor hallucis tendon passes through. And below it is a calcaneum bone having a broad calcaneal tuberosity. Next slide. Next slide. So there are various anatomical variants like accessory ossicles. What are accessory ossicles? These are actually secondary, unfused secondary ossification centers which are present in relation to bones of hindfoot. So these radiographs, they depict the labeled ones. Expected location of these ossicles, like the number at number 1 is present is the os trigonum, then at 2 os sustentaculum, at 3 os calcanea secundarius, 4 os tibial, subtibial, at 5th location os subfibulate, and 6th location supratellate, 7th tibiotellate, and the 8th at 8th location, that is the os talus secundarius. Next slide. So the first and the most common accessory ossicle, that is os trigonum. I won't go much into detail as has been well covered by Dr. Reddy. I will just show on radiograph this os accessory ossicle, that is actually the unfused lateral tubercle secondary ossification center present in relation to posterior process, and the image, which is the cursor where it is moving, it is actually a case of fracture. So we need to differentiate this ossicle from the fracture, because the fracture, it has irregular margins, loss of cortication of its margin, and combination, and of course history of trauma will be present in fracture. While trigonum, it will have smooth margins and may be symptomatic in case of os trigonum syndrome, where the patient will have the edema around the trigonum. Next slide. Next, it is the os sustentaculum. Next slide, please. Next is the next slide, os sustentacular. So this is accessory ossicle, well shown by arrow, present in relation or posterior to sustentaculum process, and usually it is present in association with the talocalcaneal collision. Next slide. It is also, we also need to differentiate it from the eversion fracture of sustentaculum, like well shown in this image. Next is os calcanea secundarius. This entity, it is present in relation to anterior process of calcanea. So shown on the right upper image, this separate structure, that is accessory calcanea secundarius, and it is to be differentiated from, as it closely mimics eversion fracture of bifurcate ligament. So it closely mimics this fracture part, which is shown by this red oval or the circle. This is a case of fracture, while on right side, these are the CT images showing the accessory ossicle. Next slide. So these are all subtibial and subfibulate, which are persistent accessory ossification centers. We can well see that the margins are well corticated, while in case of fracture, like also they mimic the eversion fracture of medial or lateral malleoli respectively. So the same points by the same imaging features, we will be able to differentiate these ossicles from fractures. Next slide. So it is a table summarizing all these accessory ossicles and their clinical importance. Next. Now next, coming to the congenital vertical talus, also known as rocker bottom foot. So it is commonly seen in pediatric population, in which child presents with the classical clinical finding, that is a convex bottom of the sole of the foot. And on this radiograph, lateral radiograph, we can see the vertically oriented talus, plantarflex talus, plantarflexed calcaneum, and this talus is seen almost in the line of the long axis of tibia. And this entity can also be diagnosed antenatally in the second or third trimester. Below are the normal images in which by arrow I have tried to show that it is a normal relationship of talus and calcaneum in the fetal foot, and on this sagittal image, while in upper image you can see that only the talus it is seen, while the calcaneum that was lying in valgus position, so it is not appreciated in the same scan. Moreover, the bottom, like convex bottom or the sole of the foot, plus in axial images, these abnormal orientation of both bones, it is seen on antenatal ultrasound. And on postnatally, these can be diagnosed by these angles, tibiocalcaneal and talocalcaneal angle. In context to tibiocalcaneal angle, the left bottom slide, tibiocalcaneal, here the angle, if it is more than 90 degree, then it suggests that the hindfoot valgus, which is seen in this seen because of congenital vertical talus. And the middle image showing talocalcaneal angle, if it is more than 40 degree, then like in the right side, it is more than 40 degree, it suggests hindfoot valgus. Next slide, please. Coming to collisions. Now collisions, they are actually complete or partial fusion of two or more bones of midfoot and hindfoot. Usually they are developmental and they can have different morphology like osseous, cartilaginous or fibrous. And usually the patient presents with the joint stiffness and flat foot. Next slide. So I'll be showing the talocalcaneal collision by these images. These are usually seen the intra-articular in context to the mid-facet joint. So this is the upper lateral radiograph. It is showing a middle facet osseous type of collision in which a continuous C or the cortical line it is seen in relation to the talar dome extending till the sustentaculum tali. So it is the C sign seen in this osseous type of collision, and this arrow over talar head, it is showing the talar beak, which is because of the abnormal mechanical strain over this talonavicular joint capsule. So that actually forms a osseous beaking or a talar spur. Below image, the MR corneal image showing this osseous continuity. And coming to the right side images, the cartilaginous type of collision, which is well seen on this sag image, and it is not middle facet, it is now the posterior subtalar joint cartilaginous type of collision. So what is the important feature? That the cartilaginous ones, they show the loss of subchondral bone plate and osseous deformity, and subchondral cysts are seen on the either side of the collision, and bone marrow edema can also be present because of the mechanical stress. While the middle images, it is showing the fibrous type of collision shown by this black arrows on radiograph and white on MR. So this type of collision seen between the posterior medial process of talus and posterior to sustentaculum tali. So it is an important location of this, and radiologists usually tend to miss this type of collision. Next slide. Next is the calcaneonavicular collision, which is again can be of three types. On this radiograph, we can see the elongation of anterior process of calcaneum fusing or reaching up to navicule, forming anteater sign. And on below CT images and BRT image, the osseous bar, it is well noted. Next slide. Now coming to infections pertaining to talus and calcaneum. Next slide, please. So infections in a hindfoot, they are very much common in diabetic population. So whenever any diabetic patient comes with a red hot swollen foot or the swollen foot with the ulceration, there is always a diagnostic dilemma for a radiologist whether to call it osteomyelitis or Charcot foot. So there are some salient points or the tips, like this osteomyelitis that will be seen in the pressure areas, weight-bearing areas like calcaneum or metatarsal heads, while Charcot that will be seen in the midfoot. So now in these MR images, we can see a well-defined or ill-defined geographic or permeative type of the lesion that is seen involving calcaneum, having a ulcer over the overlying skin, showing diffusion restriction in the center, and post-contrast images, peripheral enhancement that is noted. So this is a case of calcaneum osteomyelitis with intraosseous abscess. So it is actually a ghost sign seen when the lesion, it is not well appreciated on T1 weighted images, while it reappears on T2 or T1 post-contrast images. Next slide. Now, in this image, we can see again the patient was diabetic, and we can see the edema, it is present. Now, edema, if we will see carefully, the edema, it is seen in the subchondral region. It means it is a joint disease, not a bone disease. Now, see the location. It is midfoot, not the hindfoot. Again, patient is diabetic, midfoot involvement, it is seen. So, it is not osteomyelitis, it is Charcot joint as per its location. Next slide. Now, again, now edema, it is present, location, it is midfoot, but we can also see the other features like soft tissue swelling or a ulcer, which is highlighted or shown by this arrow. This ulcer, it is present. What we need to do, we need to place a marker over the ulcer, and we need to track this ulcer up to the underlying bone. If that track, it is continuously followed till bone, it means it is a case of Charcot with superimposed osteomyelitis. That's how we differentiate whether it is osteomyelitis or Charcot, or both are together present in a same patient. Next slide. Now coming to, next slide please. Coming to next infection, that is mycetoma foot. So it is an entity or the infection caused by the direct infection from the skin caused by fungus or actinomycetoma bacteria. In this, patient classically present with the soft tissue swelling or multiple sinus tracts as seen on these right-sided sagittal MR images. Multiple sinus tracts are seen, and these patients, they have classical nodule type of multiple nodules on T2 weighted images, which have a like classical dot in a circle type of appearance. Now, what is dot in a circle? The central dot, that is because of the fungus, surrounded by hyperintense granulation tissue, surrounded by hyperintense rim. So that rim is because of the fibrous tissue. So this gives appearance of T2 dot in a circle sign in mycetoma. Next slide. Now, these Brody abscess that can also be seen in bones of hindfoot, and which it is actually a lytic lesion, well-defined lesion with a thick sclerotic margin. We also need to be aware of this entity. Next slide. Now coming to the bone tumors. It is a long list of bone tumors I'll be like covering in subsequent slides. Now, first of all, the osteoid osteoma. Next slide, please. Osteoid osteoma. Now, this tumor, it is maybe seen in the like talus and calcaneum. Now, this appearance, as we all know that it is having a nidus with the classical reactive sclerosis whenever it is present in long bones, it is intra-articular, but it is a bit atypically on imaging in these bones of hindfoot, because it is juxta-articular and subperiosteal. Like in this CT images, we can see there is no or minimal sclerosis. It is present around the lesion. Why? Because of lack of functional periosteum in the joint. Because of this reason, this osteoid osteoma, they do not show sclerosis in the bones of foot. Next slide. Next is the osteoblastoma. It also closely mimics osteoid osteoma, gives the same MR appearance, central nidus or the osteoid type of matrix along with the surrounding sclerotic rim, as we can see on these images, and on X-ray also the sclerotic lesion, it is present, but the size, if it is more than 2 centimeter, then we label it as osteoblastoma on imaging. Next slide, please. And it closely, like it tends to involve the talar neck. This is again like osteoblastoma, a bit aggressive type in which it is seen in relation to talar neck, and a bit faint sclerosis it is seen in surrounding in this lesion, and involvement of surrounding soft tissues. And this is a feature of osteoblastoma. Next slide. Next is the chondroblastoma. Chondroblastoma, usually in talus or calcaneum, they are juxta-articular in location. Well-defined lytic lesion may present, as these are benign, so may present as a well-defined lytic lesion, may have central ring to arc-like calcification. And on these bottom images, I have tried to show that the MR feature of chondroblastoma, like they have internal lobular architecture and the surrounding lobular margin. And they have low to intermediate signal on both T1 and T2 weighted images. Next slide. They may be associated with the secondary aneurysmal bone cyst, in which fluid levels will be seen, or the blood fluid levels are seen because of this ABC. Next slide. Now, if this type of lesion is present, we also need to rule out it from the primary aneurysmal bone cyst, which are expansile lytic lesion causing cortical thinning, erosion, and showing fluid levels on MRI. But such type of lesion will not have solid component and will not have enhancement, post-contrast enhancement of solid component, but it will be there in secondary ABC. So this is an important feature to be kept in mind. Next slide, please. Next is the intraosseous ganglion cyst. Again, it may be present in vicinity of joint, can seen as a small lytic lesion. We also need to be aware of this entity. Next slide, please. And also this osteochondral defect, it is may be seen in the region of talar dome, but it will have cartilaginous defect. Next is the giant cell tumor. It will be the locally aggressive expansile lesion with the no sclerotic rim. That may also involve the surrounding soft tissue and may also involve the surrounding soft tissue and may also associated with the secondary aneurysmal bone cyst. Next slide, please. Now, next is the malignant lesions like osteosarcoma. As the name suggests, the lesion, it will have the dense amorphous osteoid type of matrix like seen on this radiograph and will also involve the surrounding soft tissue. And we can see the aggressive or permeative type of destruction of this lesion involving this soft tissue and showing intense enhancement on post-contrast images. While in talus, there will no, like in bones of hindfoot, there is a bit difference that there will be no such a sunburst type of periosteal reaction or Codman's triangle formation as in long bones. Next slide, please. Next is the chondrosarcoma. This is a chondroid matrix lesion, will have the feature of chondroid matrix and ring or arc type of calcification with aggressive features may be present by involvement of surrounding soft tissue, cortical destruction, or endosteal erosions. Next slide, please. Next, it is the Ewing sarcoma. This case has been shared with the due consent of Dr. Dharminder, in which their patient, like 14-year female, presented with the massively destructive lesion of the talus with associated soft tissue mass, and it showed the aggressive nature. On MR also, like heterogeneous PDFS or stir hyperintense signal was seen, and the intense post-contrast enhancement on axial MR was noted. And this patient also had a lytic lesion in the femur, so we suggested of, so it was a biopsy-proven case of Ewing sarcoma with bone-to-bone metastasis. Next slide, please. Now, this talus and calcaneum can be involved by, please next slide, can be involved by some non-sarcomatous malignancies also like metastasis. Next slide, please. Metastasis and lymphoma. Like in case of metastasis, the known history of primary will be present. While lymphoma, that's how we rule out that the whole involvement of whole of the marrow of calcaneum, like on these Stephen weighted images, we can see the whole calcaneum has been replaced by the lesion, and the showing the like heterogeneous signal on this proton density fat set image. So it was again a biopsy proven case of lymphoma. Next slide, please. Now here are few lesions like the calcaneum. It is very famous to get involved by lipoma, as we all know that the fat signal will be seen and the lucent lesion will be seen on radiograph, but the central calcified speck, if it is present, it represents the fat necrosis of that lesion. And below is the osteochondroma. It is osteocartilaginous growth of this calcaneum seen on the left lower slide. It is showing the continuity of the medullary cavity of this lesion with the parent bone. And the other two images, they show the this bizarre osteocartilaginous proliferation of this epiphyseal cartilage, pedunculated type of growth from the talus. So it is known as Trevor's disease. Next is a fibrous dysplasia. Again, the ground glass type of the matrix, the characteristic feature of FD, it is seen in case if it is seen on CT or on the MR, we can rule out the other pathologies and narrow down the diagnosis. And last is the unicameral bone cyst. It is the expansile, it is a well-defined lytic lesion with the thin sclerotic rim as seen on these MR images. The T2 hypointense rim, it is noted and showing the peripheral enhancement. And sometimes a fracture, it is associated that may show fallen fragment sign. Next slide. So here, this is a table summarizing all of bone tumors which involve bones of hindfoot. Next slide, please. So the take-home message from my presentation is that like the bone tumors in tarsals, they may present with atypical findings like osteoid osteoma, osteosarcoma, chondrosarcoma. They may appear differently in tarsals than the long bones. So it is very important to be familiar with these findings. And pertaining to infections, if we know the location of lesion, location of ulcer, sinus tract, we can rule out whether it is osteomyelitis or Charcot, as I explained. And collisions, again, it is very important to not to miss these collisions, especially the fibrous cartilaginous or extra-articular ones. And they are a bit associated with flat foot, and the patient usually present with the joint pains. So thank you very much.
Thank you, Dr. Harmeet, for showing the non-traumatic bony lesions and or the fantastic thing about all the tumors, the related tumors and the infections, as well as the correlation. So you covered most of the things. So thank you very much. Before I'll give it to the quiz masters, Dr. Vardhan and Dr. Ram, just to finish in two sentences, that we have seen all the presentation by our young and enthusiastic the speakers. So we can say that they are maybe the young by the age, but they presented excellently. So congratulations to all of the young people. And being the founder secretary of the society, I am very, very happy, and I was proud to all of you. And you are the backbone of the society, as well as you are new generation MSK ritualist. I am hopeful that the growth of the society in your hand, and obviously we will grow together. And it's fantastic to see your presentation. So, and second thing is, I must congratulate Dr. DK, Ram, Dr. Govindraj, and all MSS to providing this kind of the webinar, where we covered the whole of the ankle joint and with the smaller the topics, and everybody is so good in presentation. So I'll thank all the people who organized this one. And so thank you very much. And over to now to Ram and Dr. Vardhan. Over to you, Dr. Vardhan.
Yeah. Thank you, Dr. Mahesh. Now I'm just trying to share my contents. Is the screen visible, Dr. Ram and Mahesh, sir?
Yeah. Can you show next slide, please? I could see your presentation. I'm not able to see the presentation. Can you?
Dr. Ram, are you able to see my slide?
Not your slide, sir, but I can see the WebEx this thing. You have to press the share and open the PPT, sir.
Yeah, I've actually done that only. So I'll just stop sharing once. And I'll share once again. Control.
Share. Yes, sir. Yes, sir. You have to just make it full screen, sir.
Okay. That's great.
So, Dr. Vardhan, he is well known in MSK, the society, as well as MSK, the radiology, the scenario, and he's a senior consultant in HOD radiology of Sahadri Super Specialty Hospital. He has a lot of publications, presentations, and he's a recognized PG guide for the DND curriculum. And he's a very senior guy, is practicing more than 25 years. So over to you, Dr. Vardhan.
Yeah, thanks a lot, Dr. Mahesh, for the kind introduction. And I also thank Dr. Jairaj and Dr. DK Singh and MSS for making a part of this young group of me. So thanks a lot. Since we are running a little late, we'll be conducting this quiz in a slightly crisper manner. At the end of the 20 minutes, I'll stop. What we are going to do is there is going to be a Slido bar for all the delegates, and they can press the option that is 1, 2, 3, 4, and 30 seconds will be provided to you. At the end of the 30 seconds, Dr. Ram will make an announcement, and then we'll go on to the next question. So should we start, Dr. Ram?
Yes, sir. We are ready, sir. I just want
Yeah.
to, okay, sir, we'll start.
Yeah, you
Yes,
wanted to ask me something?
Yes, sir. No, sir. I wanted to know if the participants are able to see the Slido bar. Anyone in the chat box can know.
Sonali said no.
1 second, sir. I'll just press launch.
Yeah.
Yes, yeah. Some of them are saying yes, some of them are saying no. I think on the bottom hand of the WebEx, there is a 4 squares and triangle plus symbol. Press that and install the Slido. Some of them have said yes, sir. Yes. Yes, sir. We can start, sir.
Yeah. So we'll start with the first case. This patient was operated for cataract in the childhood and presented with giddiness, which was not responding to routine medications. And patients also had swelling in the posterior portions of the ankle. And these are the images for interpretation. That's the axial CT. This is the coronal T2. This is gradient axial. And these are the two axial images of both the ankles. So what's the most appropriate diagnosis? Is it cerebellar calcification, or is it CTX, that is cerebrotendinoxanthomatosis, or is it hypercholesterolemia, or is it metronidazole toxicity? So we'll start with the 30 seconds, and the participants are requested to press for the most appropriate option.
I request all the participants to vote in the Slido column.
Most of the cases have already been covered by the speakers earlier.
Sir, almost 100% of the votes have gone for cerebrotendinoxanthomatosis.
That's absolutely the right answer. We can see calcification in the cerebellar hemispheres and xanthomas bilaterally. So that leads us to the next question. Which of the following sentence is not true for cerebrotendinoxanthomatosis? Is it autosomal recessive disorder? There are defects in sterol 27 hydroxylase enzyme which participate in bile acid synthesis. Then there is mutation in the CYP27 gene, and the last option is primary bile acids, that is cholic and chenodeoxycholic acids, are synthesized in excessive amounts. Which of this option is not true? Your time starts now, 30 seconds.
Sir, 33% of them have answered autosomal recessive disorder.
Okay.
Another 33% have answered defects in sterol hydroxylase enzyme defects. The last 33% have primary bile acid, cholic, and chenodeoxycholic acid synthesized.
So there appears to be some kind of a tie in the options. But the correct answer is that primary bile acids, cholic and chenodeoxycholic acids are synthesized in excessive amounts. That is a false answer. The actual true reason is that the primary bile acids, cholic and chenodeoxycholic acids are synthesized in very poor amounts because of the first three things. I'm just unable to forward the PPT. Just 1 sec.
No problem, sir.
Yeah, now. So it's an autosomal recessive disorder, and the primary bile acids are not synthesized up to the mark, and that's the reason why there is lipid accumulation in different parts of the body. So that leads us to the next case. So these are T1 weighted axial images from top to bottom of the ankle, and this is a young athlete who has presented with soft tissue swelling on the lateral aspect. So which is the most appropriate answer? Tenosynovitis, accessory muscle, soft tissue sarcoma, or a meniscoidal lesion? Please start voting. At least 2 or 3 such examples have been shown in the presentations before.
Time's up. Sir, 56%, 59% have voted for accessory muscle,
Yeah.
35% have voted for tenosynovitis, and 6% have voted for a meniscoidal lesion, sir.
Yeah, so we couldn't have diagnosed tenosynovitis without the T2 weighted images. These are all T1 weighted axial images, and the signal intensity of this particular structure is exactly similar to muscle. So that's exactly an accessory muscle. To be very precise, it's an accessory peroneal muscle. And just to give you a brief idea, there are different peroneal accessory muscles which are described in the literature, but to avoid confusion, all of them are grouped into one category which is called as peroneus quartus muscle, and most of the times it is asymptomatic. Occasionally it can lead to crowding in the retromalleolar groove, whereby it can predispose to the attrition of the peroneus brevis tendon and subsequently its tear. So we'll move on to the next case. Or rather, this is just one more companion case, and in this case I'm showing you the accessory soleus muscle also, which I got just last week. It is getting inserted onto the lateral aspect of the calcaneum. So now next case, this was a young male who presented with pain in the hindfoot and heel region, and there was no history of trauma. So you have to spot the abnormality and give the diagnosis. Is it a stress fracture, or is it subtalar arthritis, or is it normal vascular remnant, or is it tuberculosis?
Time's up. 62% have voted for normal vascular remnant, sir, 29% for stress fracture, and 10% for subtalar arthritis, sir.
That's absolutely right. So most of us have got it right. That's normal vascular remnant. For those who want to know what is a vascular remnant in the calcaneum, there is a very good article in AJR 2005, which mentions everything about the normal vascular remnants in calcaneum. So one can refer to that particular article. So we'll move on to the next case. This was a patient who presented with sudden onset painful swelling in the region of the great toe, and these are the MR images for our interpretation. And what are we dealing with? Is it Morton's neuroma, or is it synovial sarcoma? Is it gout, or is it soft tissue sarcoma? Please start opining.
Time's up. An overwhelming amount, 78% had opted for gout, sir. Synovial sarcoma, 13%, soft tissue sarcoma, 8%, and Morton's neuroma, 4%, sir.
So most of them have got it just spot on. When in doubt, always think about gout. And when you get such a kind of an image, there is no doubt at all. So it's definitely gout. Now, just for academic purposes, this patient was subjected to dual energy CT, which we have recently installed, and this is what we got. So this entire soft tissue swelling around the MTP joint was looking depicted green, and plus we could also find some additional deposit adjacent to the fibula, as well as there were some deposits which were within the tendo Achilles. So the next question is related to dual energy CT. Now, which of the following sentence is false? So first option is twin beam technique involves 0.05 millimeter thick gold filter, which reduces the photon energy, and 0.6 millimeter thick tin filter to increase the photon energy to create a combination of 80 kVp and 140 kVp. Second option is twin spiral technique involves two separate scanning techniques by using 80 kVp and 140 kVp. The pitch of the scan is limited to 0.5 to maintain the gantry rotation time. That's the third option. And the fourth option is dual source energy is same as dual energy CT. Can you start opining?
Time's up, sir. The overwhelming amount, 83% have opted for option 4. Dual source CT is same as dual energy CT.
Yeah, that's absolutely. This was just to go through or revise little bit physics of the dual energy CT. So first three options are right and fourth is obviously wrong. Now, this patient had presented with pain in both the ankle region. And what is the most appropriate answer? Are we dealing with rheumatoid arthritis? Is it degenerative arthritis involving both the ankles? Is it hemophilia? Or is it ankylosing spondylitis? Please start voting.
Time's up, sir. Both rheumatoid arthritis and hemophilia have got 43%, while degenerative has got 13%.
Yeah, the correct answer is hemophilia, and it's very evident because the same patient's knee joint now I've kept in front of you. And had it been RA, it would have involved both the hip joints also. It has not. So the correct answer is hemophilia. Let's move on to another case. Now we have to identify the normal anatomical structure on these T1 sagittal images, which are pointed out by the arrow. So what are we dealing with? Is it a cervical ligament? Is it a spring ligament? Is it a fundiform ligament? Or is it a dorsal talonavicular ligament?
Time's up, sir. 63% have voted for cervical ligament, 25% for fundiform, and 13% for spring ligament, sir.
Yeah, so that's what actually I expected, that most of us would vote for cervical ligament thinking that it is the central portion of the sinus tarsi, but actually it is not. It is the most lateral portion of the sinus tarsi where the fundiform ligament gets attached, and the cervical ligament would be slightly medial to this. It is these are the two limbs of the fundiform ligament which are covering the tendon of the extensor digitorum longus, and it acts as a pulley to keep the extensor digitorum longus in place whenever there is excessive dorsiflexion. The same ligament is seen as a hypoechoic structure when you are doing ultrasounds, and that should not be mistaken for any tenosynovitis. So we'll move on to the next case now. This patient has presented with pain once again in the hindfoot region. So what is the diagnosis? That's the T1 axial. These are coronals, and these are PD FATSAT images. The image courtesy is because of Dr. A.B. Kesar, that's Dr. Abhimanyu Kelkar. So are we dealing with Baxter's? Your time starts, huh? Or is it subcutaneous edema? Or is it plantar fasciitis? Or these are varicosities? So we have seen most of these conditions in the PPTs which were presented before.
Time's up. 91% of the people have voted for Baxter's neuropathy, sir. Plantar
That's
fasciitis
right.
and subcutaneous edema is only 4%.
Yeah, that's absolutely right. We can see significant amount of fatty atrophy of the flexor digitorum brevis muscle because of the entrapment or compression of the Baxter's nerve. So let's not go into much into the theory because it has already been covered very well in the presentation before. Now, next case. This was a case of trauma, and these are the X-rays which are there in front of you, which are initially taken. Now, which next radiograph is going to help us the most in this particular patient based on the findings which we can observe here? Is it weight-bearing foot epilateral? Is it foot oblique? Is it ankle mortise? Or is it ankle oblique view?
Time's up, sir. Ankle mortise has received 48% votes, weight bearing 33%, sir.
Okay, so what actually we are supposed to pick up is that there is some widening of the intermetatarsal space between first and the second metatarsal. The normal width is supposed to be 2 millimeter or less than that. Anything which is more than 3 millimeter is definitely abnormal. So in this case, it's about 4 millimeter. And what this weight bearing two views have helped us is they have allowed the intermetatarsal space to widen out further. So this is a clear-cut case of Lisfranc fracture dislocation. So weight-bearing foot epilateral importance cannot be overlooked at all in these cases. So let's move on to another case. Based on these images, please give the most appropriate diagnosis. Are we dealing with an enchondroma in the calcaneum, or is it combination of Freiberg's infarction, bone infarcts in the calcaneum, tibia, talus? Is it multifocal osteomyelitis like CROM, or is it osteochondral lesion of the talus?
Time's up, sir. Freiberg's infarction with bone infarcts in calcaneum and tibia had 77% of the votes, sir.
Yeah, so that's a very self-explanatory image. Now, this is an ultrasound, and that's the video clip. You have to tell me which kind of a maneuver has been performed to demonstrate the pathology in a better manner. Please start opining. I'll keep on the clip, playing the clip once again.
Time's up, sir. Anterior talar test has received 52%, while anterior draw test is 24%. The others are 10%, sir.
There is nothing like anterior talar test or posterior talar test. There is only one test, and that is called as an anterior drawer test. By now, everybody must have identified that this is a ATFL tear. And in order to demonstrate the ATFL tear better, what we have done is we have pushed the tibia and the fibula, that is leg of the patient, posteriorly, while the foot is kept fixed with the other hand. So actually we are pushing the tibia fibula posteriorly, but still it is called as an anterior drawer test because the movement of the talus is anterior with respect to the tibia and the fibula. So the anterior drawer test is routinely performed clinically by the clinicians, and this is a sonographic counterpart of the anterior drawer test, which one must perform for all the ATFL tears. Now this patient has presented with chronic pain on the medial aspect of the foot. So what are we dealing with? Is it os tibiale externum? Is it accessory navicular bone with syndrome? Is it contusion of the navicular bone, or is it tendinosis of the tibialis posterior tendon? Dr. Ram, now there are only 2 more questions and we are almost nearing 20 minutes. Do you want me to stop? I'll stop.
No, sir, we can continue, sir.
Yeah.
Not a problem. Time's up, sir. 92% of the people have identified accessory navicular bone and syndrome, while 7% are saying it's os tibiale.
That's absolutely right. So that's the accessory navicular bone, which is now receiving the insertion of the tibialis posterior tendon. The accessory navicular bone has formed a synchondrosis with the parent navicular bone. And each time the tibialis posterior tendon is going to contract, it is going to cause disruption of this cartilaginous synchondrosis, producing edema and pain. So let's move on to the 14th question. Now, this is a case of trauma, and which of the finding would be the most worrisome finding from the clinical management point of view? ATFL tear, deltoid ligament tear, fluid surrounding the peroneus tendons, or syndesmotic injury, that is tear of the anterior inferior tibiofibular ligament tear. This has already been covered very well by Dr. Chaitali in a lecture. Low ankle sprain and high ankle sprains.
Time's up, sir. 68% have voted for syndesmotic injury, oblique anterior inferior tibiofibular ligament tear. 25% say it is ATFL.
Absolutely right. So it's a high ankle injury involving the anterior inferior tibiofibular joint with disruption of the syndesmosis. Obviously, this is going to get take a large amount of time to heal. And that's the last question. Everybody can diagnose the osteochondral lesion by now. I just want you to tell me the stage. Is it 1? Is it 2B? Is it 3? Or is it 4?
Time's up, sir. 61% have voted for 2B and 39% for stage 3.
It's actually stage 3 because 2B would have been only a cyst formation along with marrow edema, but here you can see a formation of fragment very nicely. So these are the stages. That's stage 1. This is 2A. That's the 3, and sorry, this would be 2, and this would be 3. And if the fragment gets lost, then it would become the stage 4. So thank you for patient listening and participating in the quiz. I'll stop sharing my PPT. Thank you.
Thank you very much, sir. I think Dr. Mahesh, sir, will you be taking up
No, I think it's good. So thank you, Vardhan. Showing fantastic cases and the revision of what our young the speaker has taught us in the morning. So then you have revised again and showing fantastic cases. So thank you very much, Vardhan. It's
Yeah,
always
thank you,
pleasure
sir. My pleasure.
to listen to you every time. And thank you very much again. So
Thank
now it's over to Dr. DK, Dr. Ram, and Dr. Govindraj.
DK sir,
Dr. DK is here?
Yes, sir. Yes, sir. Yes,
Okay.
sir. Okay, sir. Thank you so much, sir. And I'm really thrilled to witness a large number of delegates who have attended the conference, and in the Sunday morning. And I am quite certain that all the delegates must have been benefited from this dedicated ankle session. I extend my sincere thanks to all the speakers who did a splendid job and shown every corner of the ankle joint. The presentation not only covered the basics, but on the common clinical conditions and some uncommon also. Personally, if I will say, I have learned a lot. I have learned a lot from the session, and I must, and I confess that this was one of the best sessions of the ankle which I have heard in the recent 10 years. I am grateful to Dr. Vardhan Joshi for conducting the session, conducting the quiz in a very interesting manner, for which he is well known of. I am really thankful to Honorable President Dr. Jayaraj Govindraj sir, who is our guiding lamp and always the guardian, and our moderator, Professor Mahesh Prakash sir. The presence of you and Dr. Jayaraj sir always adds gravity to the session and always a pleasurable experience. The session was not possible without the extraordinary effort of Dr. Ramakrishna, and who had made this session a smooth one, and it's only possible by the efforts of Dr. Ramakrishna. As MSK Radiology, as you all know, the MSK Radiology is one of the most rapidly advancing subspecialty of radiology in India, and I proudly say, as a secretary of MSS, the MSS is primarily responsible for the growth of this MSK Radiology all over India, and have shown the impactful presence in all international forums, which Dr. Mahesh is a living example. So I must say, the future of MSS is in responsible soldiers, and MSS will come in the future with similar sessions on dedicated joint. I wish you all. Thank you so much, sir. Over to Jayaraj, sir.
Thank you very much, DK. As is very popularly known, he's an amazing guy. DK stands for Dynamic King and Sing. Okay, so he really took off, and it was his germ of an idea which we were all very enthused about. And each of the faculty, amazing. I must congratulate each one of you for having done so well. In fact, the discussions were so focused, so relevant, so detailed, and so practical. I think people who are practicing MS radiology would definitely be able to get the finer points, learn from these wonderful discussions, from the basics to the most advanced, and certain tips and tricks by each of the speakers, I must say, was really amazing. And as some of the chat conversations, we expressed that this has even superseded some of the major conferences in Europe as well as in other countries. So my hearty congratulations to each of the faculty, and more so to the core members who have actually worked so hard for it. The moderator, Dr. Mahesh, was amazing. He kept everything, nudging people to keep to time, and I'm very happy that we were able to finish very well. And this first experience of MSS Young Voice will carry on. Believe me, it's going to become an institution where it will be a platform for the young members of the MSS, and we will hope and see and pray that all of you all take this forward to a great future for all of MSS in India and for the whole world. So long live MSS India. Thank you so much for all of you to having spent your Sunday with us, more than half a day. And I'm immensely grateful to all the core people, the team players, Dr. Ram to be mentioned, as well as Dr. Vardhan Joshi with his beautiful overwhelming quiz. This is very much appreciated. And to each one of the faculty, you've been excellent. And I wish you all very well. have a great Sunday. Thank you very much to all of you. Over to DK.
Okay, thank you, sir. Now we are concluding the session, and I thanks and once again thanks Dr. Mahesh sir, Dr. Jairaj Govindaraja sir, Ram, all the delegates, all the speakers, Vardhan Joshi, and everyone by the core of my heart and content. Okay, I wish you all a very happy, healthy, and purposeful life and a blissful Sunday. Thank you so much for attending the conference.
Thank you, sir.
Bye.